Moments. Let's get our friends over in Facebook logged in and ready to learn with us here tonight. And the unsupported request. Could somebody check and see if we are actually on Facebook? It says we are, but I just got an error warning. It's always fun using technology, boys and girls. Give me one hot second. Okay. And we are live. Okay. It said we were live, but then it said we were not. Good evening, everybody. It is 6:30 p.m. on the East Coast of the United States tonight, and we are joined here at the HCMA Bighearted Warrior Tour with our colleagues from the HCM program at Duke. And we are going to have a very full agenda this evening. Just as a reminder, the program tonight will be recorded. You will be able to watch this later on YouTube, and you will also be able to watch in its entirety on Facebook. If you are joining us from the Facebook feed, you will not be able to ask questions from Facebook. You will need to use the Zoom link and join us in the Zoom webinar, where Q&A is not only welcomed, but encouraged. We want you to ask lots of questions tonight. So use that Q&A box at the bottom of the Zoom screen. The chat box is for technical issues that you might be having. Julie and Stacy from the HCMA team will be here to answer your questions on chat, and our faculty will answer Q&A on their talks and on HCM related questions. Remember, we're not here to participate in consult by webinar. So remember, we can't answer your very, very specific questions. So please keep your questions vague. If you need to follow up with anything after this session, please do not hesitate to contact the HCMA office. You have our contact information, and it will be in the links above and below, depending upon where you're watching this at later. It is November 16th. It is 6:32 p.m., and I'm going to now introduce Dr. Andrew Wang from the Duke University School of Medicine's Hypertrophic Cardiomyopathy program, whom I've had the honor and privilege of knowing for, I need to say, like 20 years now. Andrew, is that possible?
It's getting up there.
Why don't you introduce us to your team tonight?
Thank you very much, Lisa, and thank the HCMA for hosting this and inviting us to participate. So I'll go in order of our presenters tonight. I'm Andrew Wong. I direct our HCM center here. Following my presentation will be Caitlin Amos, our genetic counselor. I think you can see her on the screen. Then we'll have a presentation by Dr. Carmelo Milano, professor of surgery and our myectomy surgeon, as well as our one of our transplant surgeons here. That will be followed by Dr. Adam DeVore, who is Director of Medical Transplant here at Duke. We'll talk about advanced heart failure therapies, and we'll finally wrap up with Dr. Jim Daubert, who is a professor of medicine, and we'll be talking about risk evaluation and arrhythmia management in patients with hypertrophic cardiomyopathy.
Thank you so much. We're looking forward to an engaged conversation this evening. I want to take a moment to thank Julie Russo and Stacy Titus Brown. First hyphenated, I think, webinar that we've done since Stacy's changed that last name. And Julie and Stacy will be behind the scenes handling all your questions on chat if you have anything technical working with the Zoom webinar platform. So Julie and Stacy, thank you very much. And they're going to disappear for a minute. And I am going to launch a poll right now, which might be like the first time I ever remember to launch the poll at the right time. There are 6 or 7 questions here that we're going to ask so that we can learn a little bit about why you're here tonight. And hopefully at the conclusion of my talk, we can do a little bit of a roundtable and figure out what's going on out there with you and your families and how we can help you better understand HCM and address your questions tonight. So I am going to take control of the screen for a moment and tell you a little bit about what's going on here at the HCMA. Excuse me, I screwed that one up. Hold on. Gotta put that on. I have all of these people practicing their slides and I don't do it myself. So now we're in the right space. All right. So let me get started here and get some of this out of the way and tell you a little bit about what we're doing here tonight. We heard who our talks are going to be from, and we see our agenda here, and we're going to try our very best to start with being on time. And we need to thank our sponsors this evening, which include Imbria, Tenaya Therapeutics, Bristol Myers Squibb, Boston Scientific, BioMarin, Cytokinetics, Edgewise, and we have some new sponsors coming on, which include Rocket Pharmaceutical, Rocket Therapeutics, and oh Lord, there's another one that I just forgot about, but we'll get to that in a minute. I'll remember it by the end of the night. The good news is we have more people coming to the table to help us, and more partners and more sponsors so that we can provide you more services. Okay, so I want to bring to your attention that HCM Awareness Day is coming up on February 28th, 2024. Remember, ladies and gentlemen, it is a leap year, so we have an extra day in February. And we're actually planning on being in the U.S. Capitol this year for HCM Awareness Day, doing a Hill briefing. You're going to hear more information on this in the coming weeks, and we're hoping that some of you will take some time to come join us in Washington, D.C. this February to talk about things that are important to the HCM community, including good surveillance and access to novel medications in a timely manner, ensuring that all patients have access to the medical therapies that they need without being interfered with by health plans. So it's a complicated time in HCM, and we need to make sure that our policy agenda is aligned with the needs of the community. So we hope to see you in DC. Look forward to some additional information coming up in the next about 3 to 4 weeks on the details. So the core of what we're trying to accomplish with our legislative initiative on HCM Awareness Day on the Hill, and also I should mention that we're going to be doing a number of state-based webinars to engage states in the Healthy Cardiac Monitoring Act, which is looking to include all well child examinations, to include a heart health history questionnaire so that physicians can make the proper referrals to their patients for further cardiac evaluations, not just for hypertrophic cardiomyopathy, but all genetic heart muscle disorders and congenital disorders. So stay tuned for the launching of several state initiatives. We are hoping to get bill numbers from 2 states in the next couple of weeks, where we can start having you make phone calls to your state legislative offices to ensure that we move these bills forward so we can help to identify the undiagnosed. So this is a little bit more of a breakdown of what we're looking for, and that is the well child exam inclusion, professional development for healthcare providers with an online training system. We want to improve our student athlete pre-participation physicals, but not just limit it to athletes, because we know all hearts are at risk for genetic heart disease. We want to make sure that everybody has access to care and the opportunity to be assessed. So other late breaking news, the HCM Patient Journey Registry that we have been working to bring you over the past couple of months, years actually, is about to go over to our external IRB. We're using Advera IRB so that we can do some prospective evaluation of this data set. But we're also going to be moving towards getting an exclusion for some retrospective work that we wish to pull out of the registry and start getting it out into the mainstream so that researchers can see what the HCMA community actually looks like and how we can engage together to improve the lives of those with HCM through good research and collaborative efforts. So you'll hear more about this in the coming weeks once the IRB submission has been completed and reviewed. So one of the big projects that we're working on for the next couple of months is the question of better clinical trial endpoints for hypertrophic cardiomyopathy research. And we came upon an issue that we really felt that was important to bring to the FDA, to research partners, to industry. And that is some of the endpoints that they're using may not be specific enough to prove not only how well some of these drugs might be working or not, but also to make sure that we're making the argument to the payer community that these are meaningful endpoints. And as many of you have probably been asked in clinical trials or just in your daily management of your HCM, we use something called New York Heart Association class to determine how people are feeling. Well, earlier this year, the HCMA took on an initiative to start asking New York Heart Association class questions in a slightly different way. And that is, what is your good day? What is your bad day? And what is your average day? And we know with HCM, we fluctuate a lot. So in the first 30 days of the year, we found that only 5 patients out of 37 were consistently in one New York Heart Association class. So we kept that going for the whole year. And earlier this month or late last month, we had a meeting with a number of stakeholders in clinical trial development, and we were able to take a look at these patients a little bit more deeply. We actually, whoops, there's another slide missing here. Darn it. We're missing a slide. So my apologies. We were able to take a look at roughly 300 patients with HCM. And of those patients, only 22% were static in one class for the whole year. So that thing that we saw in those first 30 days of asking the question differently played out all year long. And 22% of people were average in one class, and the rest of them kind of vary. So some days on a good day, they're a New York Heart Association class 1, and maybe on a bad day, that person's a New York Heart Association class 3, which could make for some really difficult management of a clinical trial if somebody happens to come in on a bad day, but maybe they had less bad days on that clinical trial drug than they had previously. So we're trying to figure out ways that we can weight and guide this, in addition to using other PROs to help really identify that patient experience in a clinical trial. So this is an ongoing project. We're happy to say that we are working directly with the FDA on this project and are going to be bringing your voice along with other shared decision makers and those who have experience in clinical trial design to really talk about better clinical trial endpoints for hypertrophic cardiomyopathy trials in the future. So please stay tuned for updates on this important initiative. The challenges that we're going to be having are how to weight good, average, and bad days. And maybe this isn't the right guide for us, because how are we going to measure improvement in the current model? And are we missing opportunities to value stability in New York Heart Association class as a positive outcome for a trial as well? We know how complicated it can be to try to plan a day when you don't know how you're going to feel the next day. So how do we measure stability to know what you can do the next day and to have some ability to know if you're going to be able to fulfill your duties or you're going to have to take it easy that day? So we're trying to figure out some better models there, and we're going to look for your assistance in building those models as a patient community as well. So we are really happy to tell you that the Lori Fund had a great October, and we're well funded to be able to provide more grants to more people to get to HCM Center of Excellence care should they need the financial resources. So right now we are able to provide $600 travel stipends, and we've got enough money to probably get through the next 7 or 8 months. But if you are considering donating to the HCMA, a direct donation to the Lori Fund goes right into a patient's pocket and helps them get to a center of excellence for care or to a transplant center for evaluation. So if you are interested in learning more, please visit the website and you can learn more about the Lori Fund. Our Drill Doctor Heart Drill is still open, and we have accepted some additional time to participate in the trial. We have 4 AEDs to give away. All you need to do is film your drill, post your drill, and get some people to vote for it. And we will have the opportunity to give away 4 AEDs by the end of the year. So we're really trying to get this out there and put AEDs in the community. So if your community event or your church or your school or your athletic team, your house of worship, wherever you want to put an AED, just do a drill, put it up online. We're going to give away 4 AEDs. Go get the AEDs, people. They're free. You want them. Okay. This is how you do the challenge. You can do it on social media. You can practice your drill, film your drill, and you enter to win. And we have extended the deadline beyond June 16th because we didn't have enough people participate. So we're going to need more people to participate. And we would like to end this now on January 9th. So let's get this done and let's get some AEDs out there. If you've missed the last couple of episodes of Tales from the Heart, you're not really missing anything because I've been traveling so darn much. We haven't been able to film a lot. So we're going to get back on track for next year. If you have content or you have speakers you would like to see participate in Tales from the Heart, don't hesitate to send us your suggestions at support@4hcm.org. And we are more than happy to start bringing in more and more people to our Friday morning lineup of podcasting. We have over 110 episodes of Tales from the Heart already produced. And we want to get more out there and answer your questions because we know how much you love hearing and learning about HCM in various forms, including podcasting. Save the dates for the upcoming Bighearted Warrior webinars. We are going to be doing December 12th for Corewell Health, January 18th for Yale New Haven, February 8th Vanderbilt. March is probably going to be Kansas City Health or University of Kansas Health. But we don't have a date on that one yet, so stay tuned. And we are going back in person around the country. To those of you who said, hey, how come the annual meeting was in New Jersey? Well, because we're in New Jersey. But we are trying to get back out on the road to bring meetings to you around the country. We're looking at April 20th, Stanford, which is Palo Alto, California. May 4th, the Christ Hospital in Cincinnati, Ohio. And in June, we're looking to go to the University of Utah in Salt Lake. So we're back on the road. So you can start marking your calendars. We'll start sending out save the date reminders in the regions that we're going to be at. So we look forward to getting back out there and seeing you all. We've missed you. It's been a long time since we've been out there with y'all. So hopefully we can really start building this community back up. I want to remind everybody that the International HCM Summit 8 is happening October 25th through 27th. That is a professional meeting, but this year we're doing something a little different. The HCMA will be hosting Saturday night at the summit, and we will be working with some of our Center of Excellence partners around the country to have some patients come on in and join us and tell their stories at Saturday night on the summit. So look forward to opportunities to share your story there. It will be a little bit competitive. And then on Sunday afternoon, after the summit ends, we're using the same room. We're turning the room and we're turning it into a patient meeting. So they'll be done at about 12:30 in the afternoon. At about 1:30, we will start the HCMA annual meeting. And it'll run from 1 to about 7 o'clock at night with a cocktail hour at the end of the night on October 27th, which is a Sunday. So save the date, and we look forward to seeing you at the Seaport in Boston next year. Remember that November 28th is Giving Tuesday. This is an opportunity for you to donate to your favorite charities. We hope that you consider the HCMA in your philanthropic giving this holiday season. But if you're not going to give to us, we hope that on Giving Tuesday, you donate to an organization that is important to you. And that's us. Okay. I just want to say thank you to everybody for their time and their effort that they give to the HCMA, our board, our staff, our volunteers, our partners, of course, our sponsors. And I would be remiss if I didn't say thank you to Brandy and her family, for that is my heart donor. And without them, I would not be able to be with you here tonight. So I thank you all for your attention, and I'm going to stop my screen share if my mouse wants to allow me. And we now have some tallies that we can share with you. So I'm going to end the poll. And I'm going to tell you who's here. We've got 66% of the participants telling us. 35% of you are from the Northeast. 31% of you are from the Southeast. 4% from the Southwest. 12% from the Midwest. 12% from the West. 8% from Canada. And those are nothing from Europe or Australia tonight. So who is here? 69% are patients. 15% are patients and also have a family member diagnosed. 8% have a family member diagnosed. 4% are industry and 4% are healthcare providers. No Just Curious tonight. It's always fun to have the Just Curious people here. So have you or your family experienced any of the following? 31% have been diagnosed for less than 2 years. So we know that this is a pretty delicate time. You've got a lot to learn, and it's a whole new vocabulary. So go slow. We're here to help you through it. 77% are currently on medications. 46% currently have ICDs. 19% have had septal reduction therapy. 46% are experiencing atrial fibrillation. 19% of us have lost a family member, and 8% are heart transplant recipients. 69% have had genetic testing. I know our genetic counselor is going to be excited to hear that. 8% have been advised to get an ICD, but are still considering their options. 8% have been advised to consider septal reduction therapy, so they're considering their options. And at this time, excuse me, at this time, 35% of the participants tonight are weighing options on decision making for therapeutic options at this time. And 58% have been seen at a center of excellence, an HCMA recognized center of excellence. 23% have not, and 19% aren't really sure. Go look at the directory listing. So that's who we've got. Oh, I thought I was sharing it. I hit the button wrong. Now I'm sharing it. So you can see who's here. And you can see who your peers are here tonight. So I'm going to stop that share. You participated in the trial this year, traveling from Canada to NYU, but I have to put myself for others. Everything else I do is sports down. Okay. So you're interested in trials in Canada. We will get to that in the next talk, Joe. So I'm going to invite back Andrew Wang to the floor, and everybody can come back on camera, and we can get on to our next talk. And I believe we are going to now hear from Dr. Wang about medical treatments and clinical research in hypertrophic cardiomyopathy. Andrew, the floor is yours.
Thank you very much. Can you all hear me?
Yes, we can.
Great. So again, I'm Andrew Wong, and I'm at Duke University School of Medicine and Hospital and Health System. We're in Durham, North Carolina, in the center of North Carolina. If none of you have been here, it's a beautiful time to be in North Carolina. My email there is at the bottom. I'm welcome to any questions that you have to send to me. So let me see, I'm not advancing here. Here are my disclosures. I do participate in research and clinical trials and also in advisory boards. For those of you who would like to see us as a patient, the easiest way is to simply enter into the Google search Duke cardiomyopathy or Duke hypertrophic cardiomyopathy. It'll take you to this web page. There you can either use the telephone and request an appointment, or there's actually an online form shown on the bottom right there where you can enter your name, your contact, and one of our schedulers will reach out to you and try to arrange an appointment for you as expeditiously as possible. So just go and search Duke cardiomyopathy. We are a 3-hospital system in the Piedmont of North Carolina, with our main hospital in Durham, North Carolina, Duke University Hospital, which is an over 1,000 bed quaternary care referral center. We also have 2 other more community-based hospitals, one in Raleigh, North Carolina, Duke Raleigh Hospital, and another one in Durham. So geographically located, and we have a new multi-specialty building really centrally located between Duke and Raleigh, very close to the airport, that we have 2 of the floors for our cardiology services, and it really is close to a one-stop shop with regard to testing availability, all in the same place, with the exception of cardiac MRI. And we've been in this building since late 2021. So this is the background of our experience with regard to hypertrophic cardiomyopathy. So in 1996, there was the first report of alcohol septal ablation for obstructive hypertrophic cardiomyopathy by Ulrich Sigwart, and it soon was adopted in the United States. We learned the procedure and technique and performed our first in 2002. And really at that point, although I do invasive cardiac procedures, it became very apparent that this was just one small part of managing and helping patients with hypertrophic cardiomyopathy. And there were many other issues other than septal reduction therapy for patients with symptomatic obstructive hypertrophic cardiomyopathy. So I started seeing patients in 2003 and started our hypertrophic cardiomyopathy. We were very fortunate to add genetic counseling in 2010. Our genetic counselor will be presenting some information tonight, but it's not in 2010. I think she was probably 10 years old, so it was not Caitlin in 2010. In 2016, we were asked to participate and involved in the phase 1 study of mavacamten, now known as Camzyos, but before it actually had the name of mavacamten, it had just an abbreviation of MYK-461. And we enrolled really 2 of the first few patients with obstructive hypertrophic cardiomyopathy for a single dose of the drug. We were fortunate to participate in their subsequent clinical trials. In 2018, we were very fortunate to be recognized as an HCMA Center of Excellence, and we've really enjoyed working with the HCMA and Lisa in many different initiatives. In 2010, as you all know, the phase 3 results of the Explorer-HCM trial, which were positive, were announced, and we participated in that trial and had several leadership roles in that trial. And finally, in 2021, we moved into our new outpatient cardiology building that I showed you. So the objective today is for each of us to talk about what we are passionate and interested about with regard to hypertrophic cardiomyopathy. All areas of hypertrophic cardiomyopathy interest me, but one area that is particularly of interest to me is improving the level of evidence for recommendations that we make and offer to patients with hypertrophic cardiomyopathy. In 2011, the American Heart Association and American College of Cardiology came out with the initial HCM guideline. It has been updated in 2020 and will be updated again this year very quickly because of the rapid change in knowledge and evidence for hypertrophic cardiomyopathy. But in 2011, and this is not far off from where it is now, if you look at all of the recommendations, 132 recommendations in the American Heart Association guideline for how to treat hypertrophic cardiomyopathy, 0 of them had a level of evidence A. And they're rated as you would your grade on a test, A, B, or C. So 0 of them had level of evidence A, meaning that they were the strongest level based on randomized trial. The majority of them had level of evidence C, meaning predominantly supported by expert opinion and some observational studies and case series. If you then look at what is considered class 1 recommendations, meaning highly beneficial, likely to be beneficial recommendations for treatment or management of hypertrophic cardiomyopathy, and this includes, all the range of testing for hypertrophic cardiomyopathy as well as treatment for hypertrophic cardiomyopathy. There were 54 that were given class 1 recommendations, meaning likely to be beneficial. 0 had a level of evidence A, and 59% had a level of evidence C. So not very strong evidence, but it is the best that we have, and hopefully getting better. We have participated in multiple randomized trials of novel therapies for hypertrophic cardiomyopathy, not only, I think, to benefit patients, but also to add to the evidence, the level of evidence that we have for the best treatment for patients with hypertrophic cardiomyopathy going forward. And we're a site for the ongoing Odyssey trial of mavacamten and non-obstructive hypertrophic cardiomyopathy, the MAPLE HCM trial, the phase 2 trial of aficamten versus metoprolol for obstructive HCM, and the DISCOVER phase 4 registry of obstructive hypertrophic cardiomyopathy and its management. we are going to try to offer some case vignettes to give an example of things that we are interested in, what really inspires us. So I'm going to present to you a case of a 72-year-old man with obstructive hypertrophic cardiomyopathy who had NYHA class 2 symptoms. His echo showed a maximal septal wall thickness of 2.0 centimeters, and he had a high resting left ventricular outflow tract gradient of 89 millimeters of mercury with a Valsalva gradient of 118 millimeters of mercury. And he was interested and participated in the Explore HCM trial in 2018. It was a 30-week trial, and at the conclusion of that trial, he then opted to stay in the long-term extension trial where all of the patients received mavacamten. And it was really to evaluate the longer-term safety and efficacy of mavacamten before its approval. Remember, in March 2020, the world shut down in the pandemic. And so he, as well as many other patients, continue to participate in clinical research throughout the pandemic. And I am both inspired and amazed and grateful for their participation in clinical research during the pandemic. I was remembering 2020, and we actually had patients show up to their appointments, check in, go back to their car, wait in their car because we would not allow patients to gather in the waiting area. And then we would call them on their cell phone to tell them that it was their time to come directly into the appointment room after screening. So not an easy process to participate in a voluntary clinical trial, but it ended up being a very important contribution for these patients. So I graph out here his course: NYHA class, his severity of symptoms, his left ventricular ejection fraction on mavacamten therapy, his resting left ventricular outflow tract gradient, and his Valsalva gradient, as well as some comments. So in May of 2020, soon after the pandemic started, he was doing very well on his study drug dose of mavacamten. Ejection fraction was normal, no heart failure symptoms, very low outflow tract gradient from a baseline that was very high on treatment with metoprolol and mavacamten. In August, he developed atrial flutter. His ejection fraction fell a little bit, but he was relatively asymptomatic. It was almost incidentally detected. He had still very low outflow tract gradients, and he underwent a cardioversion. He shows up then 3 months later, week 60 now, of open label mavacamten. So a year into open label mavacamten therapy, now with NYHA class 3 symptoms with recurrent atrial fibrillation. His ejection fraction has fallen to a below normal level of 35%, and he has no resting or Valsalva gradient. Now, because of the safety concerns, his study drug mavacamten was discontinued at that point. And this was the time frame where it was hard to get elective procedures like an AFib ablation done or an atrial flutter ablation done because of the concern about COVID in the hospital, as well as a reduction in elective procedures. In that same month, he elected to stop study participation after stopping mavacamten, and his ejection fraction soon recovered within the same month to 50% with very low gradients. In March of 2021, now off study drug, still on metoprolol, his ejection fraction is fully recovered. He has had an ablation of atrial flutter, and now his resting gradient is as high as it was at baseline. He shows up a year later and now starting to have presyncope, meaning lightheadedness with physical activity, still a very high resting and provocable gradient. At that point, mavacamten was not yet approved, and I talked to him about septal reduction therapy, specifically surgical myectomy, because he's an otherwise healthy person, a good candidate, but he declined it. He subsequently did begin commercially available mavacamten, Camzyos, And as of his last check 1 month ago, NYHA class 1, EF is normal, very low gradients on metoprolol and on Camzyos. And I show you here several of his representative transthoracic echocardiograms, the arrow being the left ventricular outflow tract. You can see when his ejection fraction fell to 35% due to atrial flutter, and you can see the abnormal rhythm at the bottom of the screen, that the strength of the heart is reduced, but there's no systolic anterior motion of the mitral valve, and there was no outflow tract gradient. In March of 22, prior to initiation of mavacamten, he now has NYHA class 2 symptoms, some dyspnea, but also mostly lightheadedness with physical activity due to systolic anterior motion of the mitral valve shown under the arrow with a very severe left ventricular outflow tract gradient, and his ejection fraction is now back to its sort of hypercontractile state of 65%. And then now more recently on Camzyos, still has a preserved ejection fraction, still has some systolic anterior motion of the mitral valve, but very low gradient and improved symptoms. One of, I think, the most convincing results of the Explorer trial was its benefit on quality of life, as the patient-reported quality of life. As Lisa described to you, there are challenges with using the New York Heart Association class. It has a limited range. Most patients are really between class 1 and 3, not class 1 and 4. 4 we rarely see in hypertrophic cardiomyopathy. And symptoms vary over time. The quality of life score here is a measure of the previous 2 weeks. And as opposed to a physician interpreting what a patient describes as their symptoms and applying a New York Heart Association score, this is the patient answering questions about what they feel, what they can do, and what their limitations are. They're directly answering questions, and that calculates a score. And you can see shown in red there that the patients treated with mavacamten in blue had a significantly greater improvement, or a higher percentage of them had a very large improvement in their quality of life score. 36% had a very large improvement in their quality of life score compared to 15% in the placebo group. And so the number needed to treat to see that very marked improvement in quality of life was only 5 patients. On the other side, on the far left of the screen, you can see the number needed to treat to prevent worsening of symptoms during the 30-week treatment. And you can see the number needed to treat to prevent patients from developing more severe symptoms or reduced quality of life was 7. So when we talk about the goal of any treatment for obstructive hypertrophic cardiomyopathy, is largely for improving quality of life. Our HCM program is a large program. Both patients and our care providers and team, our cardiologists, include myself and Dr. Deepa Upadhyay, our cardiac imaging, our echo lab director, Sri Vemulapalli. Dr. Han Kim is our MRI expert. EP, we have Jim Dalbert, who you'll be hearing from later today, and San Al-Khatib. CT surgery, Dr. Carmelo Milano for myectomies. Advanced heart failure transplant, you'll hear from Dr. Adam DeVore, our medical director for heart transplant. Interventional cardiology for alcohol septal ablation, Dr. Todd Kiefer. Our genetic counselor is Caitlin Amos, and our pediatric cardiologist for those families with younger children is Dr. Andrew Landstrom. Really, one of the best things, there are many great things about being in the HCM field, but one of the best things is this team that I get to work with. I would trust and really be very satisfied to have any of my family members cared for by this team. And to me, that's really reassuring that our patients are getting very good, thoughtful care, but it's a great team that I enjoy working with as well. So this is our outline today, and I will turn this over, if there are no questions to answer right now, to Caitlin Amos, our genetic counselor.
Let's just come in here real quick. Does anybody have any questions specifically to Dr. Wang at this time? We can answer questions at the end as well. Excuse me.
Bless you.
It's a cough, but thank you. So, oops, hold on one second. So we do have one question from Dan R regarding Center of Excellence listing. And I think the HCMA team can drop that link in the chat so you can see where to identify the HCMA Center of Excellence listing. So we can answer that. Oh, it's Stacy just dropped it into your question there. And maybe the team can also drop that in the general chat so everybody else can see it. So there is a question for Dr. Wang, and that is, why do you think in your patient example, mavacamten dropped the EF so low, but now they're taking it and it's stable? Do you think that there was an interplay with the atrial fibrillation in that case?
Yes, that's exactly right. We have seen that in other cases. And in fact, the labeling of Camzyos says that in patients who develop an intercurrent illness, such as atrial fibrillation or flutter, that there be more close follow-up to catch any reduction in the left ventricular ejection fraction before the patient develops heart failure symptoms. So we do see that interaction or effect. So you're exactly right.
And there was an interesting paper or abstract at AHA this last weekend, and I believe it was from Libin Wang at Maryland, currently at Maryland, soon moving to Boston. But he presented a poster showing a number of HCM patients who went on mavacamten or Camzyos after the label indication was presented, that were showing a little bit higher incidence of atrial fibrillation. Have you got any insight on if there's already existing AFib, what might need to be done to minimize risk of additional atrial fibrillation in the face of Camzyos?
That's a very good question, a very important concern. There was no signal in the Explorer trial or the Valor trial of higher ventricular or atrial fibrillation rates among the safety events. Obviously, how it behaves in a larger a real-world population is very important. Patients who had paroxysmal atrial fibrillation, in order to be in those trials, had to have very well controlled paroxysmal atrial fibrillation or persistent atrial fibrillation and no recent event within 6 months. So when it gets out into the real world, that's not a restriction. Patients could have had an AFib event 3 weeks ago, not 6 months ago, which was the trial exclusion criteria, that you could not have had a recent event within 6 months to get into the trial. But in the real world, you could certainly have paroxysmal atrial fibrillation and be on Camzyos.
Thank you for that wonderful answer. So we have a viewer who's not used to our terminology. Could you just run through New York Heart Association class and its definition, please?
Yes. So this has been around, this classification, because it's from the New York Group of Cardiologists since I think the 1950s or so. So NYHA class is really no heart failure symptoms, no dyspnea on exertion during normal or even greater than normal activities. NYHA class 2 symptoms means that a patient has heart failure symptoms, dyspnea, fatigue at a more than normal level of physical activity. So if it's, for example, higher levels of exercise or doing, a longer walk or anything like that, that is usual that you develop symptoms. New York Heart Association class 3 is heart failure symptoms, dyspnea with daily activities. Example, walking up one flight of stairs at your house, or walking to the mailbox and coming back, or doing your grocery shopping would be New York Heart Association class 3. And New York Heart Association class 4 is really dyspnea doing minimal activity, getting dressed, showering, doing minimal activities would be New York Heart Association class 4. As Lisa said, that is highly variable, not only in hypertrophic cardiomyopathy, but in heart failure patients in general. There are good days and bad days, and therapies can change it one way, and progression can make it go the other way. So I think it is a crude, meaning not lewd, but a very coarse measure of how someone is doing. And getting to your point about needing more relevant clinical endpoints for the patient perspective, quality of life questionnaires are getting us closer there, still not perfect.
We are still working on it. Okay, Caitlin, we're going to come up to you next, and we're going to talk about a really important topic in today's world, because we are in the day of the first gene therapy has happened. This is the first Bighearted Warrior Tour since this big thing happened in October. So the very first patient was dosed in the Tenaya Therapeutics clinical trial for myosin binding protein C. We don't have any we don't know the outcomes of that trial yet. Right. Obviously, it's one patient got dosed with one dose. But what we know so far, as of the word I heard at AHA, the patient is still doing quite well. And we're waiting for more readout information, which is going to come in a couple of months. So exciting times for genetics. So Caitlin, why don't you tell us a little bit more about what's going on?
Yes, I'd love to. It is really an exciting time for genetics. I'm going to share my screen.
And go right ahead. Make sure you get that all set up, and then I'm going to disappear for a few minutes.
Okay. All right. Can you guys confirm it's the right screen?
It's the right screen. You're
Okay,
good to go.
Great. Well, like Lisa said, my name's Caitlin. I'm a genetic counselor, obviously at Duke, and I see adult patients with inherited cardiac conditions, and most of those are hypertrophic cardiomyopathy. So if someone comes to our center and is diagnosed with HCM, or they're suspected to have it, they're going to be given the option to see a genetic counselor, which is me, and have a genetic counseling appointment. I'm part of a larger team. Obviously, most of that team is here tonight. And I think one of my primary jobs, or the way I see it, is as part of this team is to gather more information about a patient and their family, to give to the providers, to give to the doctors, to use like puzzle pieces so we can sort of put together the whole picture of your story. And I just like to think about that because it takes lots of different people to sort of care for a family and a person with HCM. Let's see. I know that because of HCMA, and also because Lisa told us that 70% of you guys have had genetic testing so far, that you are very knowledgeable already about HCM genetics, and honestly probably could teach me quite a bit of this. So this may feel a little bit like a review for you, but I think that in my own experience, it's always helpful to do that review, to go to the very background and basics, and just kind of recall why certain recommendations exist, because this is sort of how we think about things from sort of the bottom up. And so my plan today is really just to briefly talk through different pieces of genetic counseling, or a genetic counseling appointment, which is family history, clinical screening, and then the genetic testing. I'll drop in and give a little bit of an example scenario. It's a little bit different than Dr. Wong's. It's going to be theoretical, but that way, hopefully you can sort of visualize what this process might look like. Okay, so when I first meet with a patient, like I said, in a genetic counseling appointment, most of our time together is really spent talking about family history. And I know a lot of patients know that when they go to the doctor, they're going to be asked about family history questions. Does their dad or mom or grandparents have a heart problem or have hypertrophic cardiomyopathy? But as a genetic counselor, I do like a supersized version of this. I try to obtain information person by person in as much detail as possible for at least 3 generations, if not 4. And that's usually going back to a family member's grandparents or great-grandparents. And I collect all this information in a family tree that you can see here. We call it a pedigree. And that goes in my notes so that other doctors can reference it and see it, like I said, as they're sort of pulling together the different pieces of your puzzle. And so this is a snip of one that I actually use in clinics. This is a family that I've seen in clinic. In a pedigree or in a family tree, circles represent females assigned at birth, and squares represent males assigned at birth. And then we can kind of see patterns in how things are moving through a family. The reason that I spend so much time on a family history, sometimes patients are like, wanting to move on. But it's because we can use it to sort of look backward. We look, like I said, at different patterns in a family to try to get a sense of what does hypertrophic cardiomyopathy look like in this particular family. What are the ages of diagnosis and what are the symptoms that we're seeing? Can we decide what side of the family, maternal or paternal, that hypertrophic cardiomyopathy is coming from? And that kind of gives us a sense of who else might be implicated in the story. We can also use it real time because I'll ask questions about, has anybody died suddenly or died young? And having a family history of sudden death is information or a puzzle piece for a provider to decide if they want to consider talking about a defibrillator for you. And then we kind of use it looking forward as well. I think about it as like a map where we're trying to identify or pinpoint or just capture who else in your family might also need an evaluation down the road. Okay, so this is my example. Let's walk through this example. Obviously, it's not a real family, but let's say I'm seeing a young female patient who is recently diagnosed with hypertrophic cardiomyopathy, and so she's meeting with me for genetic counseling. So when I'm talking through her family history with her, I'm going to ask her if anybody has a diagnosis of HCM. I'm going to ask her if anyone has had a pacemaker, or defibrillator, if anyone has had a heart attack or seizures or strokes, or if anyone has fainted, if there's anyone in the family that's just had unexplained fainting spells for no reason, or if there's any other suspected heart problems or genetic conditions. So in this example, we're going to say that this patient tells me that her dad died in his 50s from a heart attack, but he really didn't like going to the doctor, and so she doesn't know a whole lot else. Her sister recently had to get some kind of device. She doesn't know if it's a pacemaker or a defibrillator. And then she thinks that her niece maybe has had a couple episodes of passing out, but they're not super close, and so she doesn't have a lot of detail about that. You can see if you just kind of zoom out, there's at least one person in every generation of this family tree that's really caught my attention. And I think this gives a really good visual of what we can call the inheritance pattern, or how HCM moves through the family. And that inheritance pattern is called autosomal dominant. And so this is sort of a flashback to Punnett squares that you maybe did in high school biology. But this is the way that HCM gets passed through a family. So just as a quick review, everyone has 2 copies of their genetic code in all of their cells because they get one from their mom and they get one from their dad. And that means that everybody has 2 copies of all the genes in their body. And so autosomal dominant is really just a fancy way of saying that it only takes a mutation in one of your 2 copies of an HCM gene to disrupt how that gene works and put somebody at risk for developing the condition. Sorry about that. So when a person who carries a disease-causing gene mutation on an HCM gene goes on to have children, they're going to either pass the copy on with the mutation that predisposes somebody to HCM on, or they're not. And so this is how we come up with a 50% risk that we talk about when we say that if somebody has HCM, there's a 50% chance of it being passed on to the next generation. This is also how we know that this condition doesn't skip generations. And I think that's something that comes up a lot, because when we think about genetics, we think about there's lots of misconceptions about thinking about how genetic traits can skip generations. And we know that that's not true because of the way that this is inherited in a family. And so again, because we know how it moves through a family and we know that there's a 50% risk, this gives us a really clear picture of who else in a family might be at risk, and we can identify that even before we talk about genetic testing, even before we get into sort of the technological piece that's really exciting about this condition. We know that an individual's first-degree relatives, which is their children, their siblings, and their parents, that all of these close biological relatives have a 50% chance of also developing the condition. And because these are the members of the family that share half of somebody's DNA. So then based on this risk, we have guidelines that recommend that these close biological family members or these first-degree relatives of someone with HCM have clinical evaluations. So evaluations of their actual heart with echocardiograms or ultrasounds of the heart and EKGs throughout the course of their life. And how often somebody needs to have those clinical screenings, like how often they need to show up at the cardiologist's office, it depends on age. Like I said, this is a snip from sort of the most recent HCM guidelines, which Dr. Wong said we're going to update this year, which is exciting. But in our clinic, we generally say we want first-degree family members to come in every 1 to 2 years until they're an adult. And so from ages 10 to about 21. That's our recommendation. And then every 5 years after that, we're in the setting of new symptoms developing in somebody. And this ongoing screening, so somebody coming in over the course of time, is really important because we all know that HCM can develop at different ages and can show up in different people at different times. And so we don't want to miss something in a loved one. So instead of everybody in the family, every first degree relative that I have circled here, children, siblings, and parents, having to get echocardiograms over the course of their life, as you all know, we have the option of doing genetic testing, which can potentially clarify who exactly in the family is at risk, and then even better, who's not at risk. Generally, I think about genetic testing in hypertrophic cardiomyopathy in sort of two different flows. And so the first one is we call diagnostic genetic testing, and that's doing genetic testing in the first person in the family that has the condition. So the first person that shows up at the HCM clinic at Duke is we call them the proband, and we're going to do genetic testing for them to try to clarify their diagnosis. So we're going to try to pinpoint through genetic testing the underlying cause of their HCM and make sure that it's really what we think of as true hypertrophic cardiomyopathy and not one of these look-alike conditions or these mimickers, which there are other types of conditions like Fabry disease and amyloidosis that can look like hypertrophic cardiomyopathy but have a totally different treatment plan. And so it's important for us to help to distinguish what the condition actually is. And then we can also, when we do diagnostic genetic testing, we're hoping to pinpoint, like I said, the family mutation, the genetic change that is causing disease in the family, so that we can use that later on. And then, as Lisa noted, besides just the current treatment that differentiates between HCM and look-alike diseases, we're on the cusp of some really exciting clinical trials for some novel gene therapies. And so this genetic testing can really set somebody up for being eligible for those. The other sort of flow that we think about is that once we've identified the underlying cause of genetic testing or genetic HCM in a family, we've pinpointed the genetic mutation, then we do predictive genetic testing. And that's something that we cascade, we start offering that gene test to everybody's first degree relatives that I've circled on other graphs. Like I said, this helps us identify who needs to be following in a cardiology office and getting those echocardiograms and who doesn't. It helps us detect HCM at the very, very earliest signs of it. And so we can have an early diagnosis. And other times we get to clear people from having to do ongoing screening. So whenever you're going through the process, and I'll go quickly through this since most of you guys have had the genetic testing, but I think one thing that's really important is that you meet, or that an individual gets to meet with somebody that's knowledgeable in genetics before they go through this process. There's a lot of logistic details and there's a lot of family sort of implications from this. And so someone would have what we call pre-test counseling. They would give us a sample, so maybe a blood sample or a cheek swab or a saliva sample that would be sent out to a commercial genetic testing lab. I've given a list of a few. There's quite a few that can do genetic testing these days. The lab will analyze somebody's genetic code or DNA, that gene panel, and then that will come back as a report to myself and the doctors I work with, and we will either have a phone call or an actual appointment with you to sort of discuss what the results found or didn't find and how you can share that information with your family. Again, kind of thinking about these two different flows from the diagnostic and the predictive genetic testing. So for the first person that we're testing, we're doing a gene panel. We're looking at lots of different genes because we're kind of being detectives and trying to find the underlying cause. And then once we do that, we pinpoint the underlying cause. Then we do what we call targeted genetic testing, where we're just looking at that one genetic change in each individual family member. Okay, so let's talk a little bit about the possible outcomes of genetic testing, the different results that can happen. Again, for the first person that's getting tested, there's one of three results. Somebody can have a positive result, which means, like I've said many times, we found the actual mutation, the disease-causing mutation that confirms somebody's diagnosis, clarifies what they have, explains why they developed HCM, and it gives us something to look for in family members. Somebody can test negative, which means of the genes that we asked the lab to look for, there was no mutations, there's no changes sort of in that genetic code. And a negative genetic test is honestly sort of a harder one in HCM because while it means we didn't find an underlying cause, we only really find that about 40% of the time. And so that means the other 60% are mostly going to get negative genetic test results. And a negative genetic test result in this condition doesn't mean that your hypertrophic cardiomyopathy is not genetic. It reduces that chance. It could mean that there's multiple genetic factors and other environmental factors involved, but it could just mean that there's part of the human genome that we've not quite understood yet that is associated with this condition. And so a negative result really is not helpful for the family. It doesn't hurt anybody, but it's not super helpful for the family. And then we can get what we call an uncertain or variant of uncertain significance. And we'll come back to this, but this means that the lab found one or more than one changes in your genes that we just don't have enough information right now to understand what it's doing. Is it contributing to your history of hypertrophic cardiomyopathy, or is it maybe just kind of background noise that we weren't expecting to find? And so then if a person tests positive for a clearly disease-causing mutation, like I said, that's the most helpful because we can use that and predict testing of first-degree relatives. We call this cascade testing, like I said earlier, and that means that somebody is either going to be positive or negative, and if a family member tests positive, then we know that they need to be proactively seeing a cardiologist and followed over time because they're at risk for developing the family disease. And then if they're negative, then we get to, like I said, offer the reassurance and tell them that they're not at risk of developing this disease and they can't pass this on to any future children. Okay, just circling really quickly back to the variant of uncertain significance, because I think this is one of the harder results for patients to get, but it's a harder result for providers to get as well. And this is sort of a picture of the spectrum of when we're looking at mutations or changes in somebody's gene, where that can fall. So is it falling in the place that we know it's damaging the heart muscle, it's damaging the protein that the heart muscle needs, or like I said, it's very, very harmless, it's just background noise. And for context, I always like to remind patients that that everybody's genetic code has thousands of mutations or variants in it. And most of the time, those variants are harmless. They just make us different, but they don't actually cause disease. There's only a few rare ones that are disease-causing or pathogenic variants. And so when we get one that we don't have a lot of information about, it falls in this sort of no man's land that you can tell on the spectrum is actually quite big. And not all variants are, not all VUSs or uncertain variants are alike. Some of them might be in that middle ground, but kind of lean one way or another. And there's various ways that we can sort of try to elucidate a little bit more information about it. But until we're really confident about what somebody's genetic variant of uncertain significance means, we don't want to use that in family members predictably because we don't want to misattribute risk. We don't want to tell someone in your family they're at risk if we find out later that they're not. And we don't want to clear somebody from risk if they actually are at risk. And so we sort of just put this on the shelf. But what I also like to say is that labs are continuously reviewing these genetic variants and we're gathering more and more information over time. And so they usually don't stay uncertain forever. They usually get reclassified. And in my time at Duke, I've been here for a little over 2 years and had a patient who had genetic testing and got a variant of uncertain significance. That was in 2021. And just this last year, it got reclassified because we had seen it in enough other people with hypertrophic cardiomyopathy and had done some other studies in it. And so now this variant of uncertain significance became pathogenic, and it's something that this patient can use to share with their family members, which is really exciting. Also, for the sake of time, and since most people have had genetic counseling, I won't spend as much time here, but I wanted to come back to say that the conversations around genetic testing are really important, whether it's with a genetic counselor, it's with another knowledgeable genetics provider. And that's because genetic testing is a little bit more involved than some other medical tests. There's obviously implications for family members, there's implications for future therapies. There's insurance implications. There's things that you should be thinking about if you're family planning. Sometimes there's specific dynamics or sort of hard conversations that come up between family members. And so because of all the sort of layers of it, even on the front end and the back end of genetic testing, I think it's really important that, like I said, that you're having a conversation before and after your test results come in so that you can ask questions and really have a good understanding of what's going on. All right, so coming back to my my patient that we haven't really talked about a lot since the beginning, but we're going to come back to her, and I'm just going to sort of pull all these pieces together so that you guys can visualize how these different parts of possible results can affect different family members. And so if our first person that came in and had hypertrophic cardiomyopathy had genetic testing, and we found the disease-causing gene mutation in her that caused her hypertrophic cardiomyopathy, She shared that information with all her family members, and some of them decided to get testing. And so we're going to go through each one. So this is our main patient, and we'll say one of her daughters tested negative for the disease-causing gene mutation. And so that's great news. She is not at risk for developing this condition, and she can't pass this condition on. Our patient had another daughter who tested positive for this genetic mutation, but right now she's asymptomatic and she's had an echocardiogram and her heart looks normal. And so that's really reassuring. But because she carries that risk, we would want to keep seeing her over time to make sure that she doesn't develop disease or be there when she does. And then we have another patient another family member, a son of our first patient, who doesn't want to get genetic testing. He doesn't really think he would use that information, or it kind of scares him to think about how he might react. And so, I think that's a good illustration that not all family members are going to process medical information the same way or think about risk the same way, and that's completely normal. But even if this patient's son doesn't get genetic testing, we still know that he could have that 50% risk, and we want him to be seeing a cardiologist and have those echocardiograms. And then we have one son in this family who tested positive for the disease-causing genetic mutation. He's already showing some signs and symptoms, but now we know sort of what that's connected to and can take better care of them. And so I'll kind of wrap up there and answer questions. But I think, as everyone knows on this webinar, this HCM is a family heart condition. And so even though we're often seeing one patient at a time, that has implications for the whole family. A family history helps us understand what it looks like in a particular family, and then whether it's genetic testing or clinical screening or both, the whole family needs to be involved in this process.
Caitlin, thank you so much. And while we're waiting for some questions, did you have any other slides? No, you were done.
No.
Thought I was jumping in there on time.
Yeah, no, great.
So we have a lot of different panels that are available today.
Yeah.
Is there something to be said about the size of the panel that you are using? Should you target? Should you go broad? What are your thoughts as a genetic counselor?
Yeah, I think that it just depends on who's ordering the test. And so, we certainly have data to say that the sort of broader that we go with, generally with inherited cardiac conditions, the sort of chance of finding an underlying cause increases incrementally. That said, we know also the really specific, we call sarcomeric variants, or genes that are associated with hypertrophic cardiomyopathy. So if you were going on the smaller end, you would want to have at least those 8 sarcomeric genes. I tend to fall somewhere in the middle. So I choose a panel that is close to about 60 genes. It's the sarcomeric genes, and then it's all those genes that are the lookalikes, the amyloid and the Fabry, so that we're not missing anything in that category. And that's really where I stay. But I think that again, if you're in a center where you have a genetic counselor who can talk to you through all the variants of uncertain significance that can come up on a big panel, versus if you're at a place that maybe a cardiologist is less aware of that and just wants to do a more targeted panel, I think it kind of depends on who can talk you through the results.
I think that's the value of genetic testing today, is to really take that deeper dive. But we do have a lot of variants of uncertain significance, which you brought up so eloquently. And I think that becomes a big challenge for people as they're trying to navigate, what does this mean? And I think people are often challenged by the concept of no mutation identified, which is also called a negative. Can you talk about what a negative result actually means?
Yeah. So I'm glad you brought that up. I think that is something that I often have a lot of conversations with patients beforehand, but we still have to talk about it a ton on the other end, because it's conceptually hard to grasp. But this genetic testing is if we have a family and a person in a family that we just had a crystal ball and knew slam dunk that this family had a genetic form of hypertrophic cardiomyopathy, it's still not 100% guaranteed that we'll find the genetic cause. And so we could do genetic testing, so only 40% of the time are we actually going to be able to pinpoint that underlying cause. And so that means that there's, again, 60% of people who might have genetic hypertrophic cardiomyopathy that we just haven't we haven't pinpointed that sort of genetic association yet. We're not looking for it on our panels because we don't know that it exists. And so somebody thinks it's a negative, a no mutation gene test result, or a negative genetic test result, it could be one of two things. It could be there are multiple sort of genetic factors, including and environmental factors, and maybe it's not what we think about as being single gene disorder, or it could be it's something on the genetic code that we haven't quite pinpointed yet, but it's still being passed through the family, and so it was missed on this test. And since we don't know where a negative genetic test result lies for somebody that we're seeing, we don't want to miss anything. And so a negative genetic test result means we just focus on their heart, and we're doing echocardiograms regularly to not miss anything.
Fantastic. And given the fact that today there are therapies specific for ATTR amyloid, Fabry's disease, Danon disease, and there may be specific gene therapies coming to particular genes for HCM, I think it's more important than ever to ensure that you've had genetic testing to see if you're in that 40% that we can identify, and then we might be able to be a bit more actionable on those items.
I think that's exactly
Trials
right.
are coming, and as more trials come, more genes will be open to potential research. So, 2005, we started talking a lot about genetic testing. And I think we've learned a whole lot in 20 years or thereabouts.
Yeah.
But I'm almost wondering if we didn't do ourselves a little disservice back then by making genetic testing be seen differently than echocardiogram or EKG testing, when the clinical relevance of that test result is kind of equal now. We have the Genetic Information Non-Discrimination Act. You can't lose access to educational opportunities, employment opportunities, or health insurance based on your genetics, just like you can't based on any other pre-existing medical condition. So maybe it's time we demystify genetic testing a little bit and make it just like every other test. What do you think?
Yeah, I think that's absolutely right. I think that, there's still in the predictive realm, as you mentioned, the genetic non-discrimination information non-discrimination act is wonderful and protects so many people from sort of the implications of health insurance and employability. But there are still a few things with that doesn't cover, like life insurance and disability insurance for predictive testing. And I think that as long as we're incorporating that in the conversation, I agree with you that sort of we're at a point where there's so much more actionability and future actionability for somebody's what we call genotype or their genetic test result, that I think it should be offered to everybody and hopefully encouraged in a lot of ways.
I would agree. We do have a question about timing. How long does it take for somebody after a swab is done to get a test result?
Yeah, it's so much faster, even just in the 2 years I've been here. So I typically tell patients from the time they've dropped the swab off in the box or they've gotten a blood draw that it's anywhere between 2 or 4 weeks. But I think I was just telling Dr. Wong the other day, we got a result back in 9 days. And so there's anywhere between sort of, now I'm guessing like a little week and some change, and 3 weeks is probably a turnaround time. So it's quite quickly at this point.
Wow, I can remember when it was like 3 months.
Yeah.
It took a lot longer. So next gen sequencing is really pushing it forward and we're able to
Right.
get results faster. That's great. That's really great. Okay, well, I don't see any other questions popping in. I'm sure we'll have some at the end of the evening. So Caitlin, thank you so much. And we are going to ask, you're not taking questions with hand raises. You got to go to the Q&A box. So if you do have a question, type fast and we can get them addressed. So there we go. Carmelo is going to talk to us about surgery next. People love and hate the surgeon. And I know that's a rough relationship to have, but we need you, but we're a little scared of you guys because you have, scalpels and things.
Understandable.
So how do we demystify surgery, and how do we let people know when it's a really good option for them? So why don't you go to your slide share and tell us a little bit about the surgical approach to managing HCM? It's almost there.
Again, thank you for
Thanks.
the opportunity to speak at this webinar. And I hope that some of the patients, find my remarks interesting or useful. My name's Carmelo Milano. I'm one of the surgeons here, and I do many of the myectomy procedures that are done at our center. It's been alluded to a few times, but surgery or myectomy is particularly focused on treatment of symptoms. And we've already mentioned that sometimes that's hard to gauge, but many of the patients that I end up seeing are extremely limited, and very, very bothered. Their lives are disrupted by the symptoms. So those patients, have an option. So myectomy, or removal of some of the septal muscle, is a treatment for patients who are having symptoms, but it is only a treatment for part of the patients with hypertrophic cardiomyopathy, because there are a significant fraction that do not have obstruction. So it's specifically for patients who have hypertrophic obstructive cardiomyopathy. And these variants, these pictures of hearts on the left, they have thickened heart muscle in the left ventricle, and they meet the diagnostic criteria for hypertrophic cardiomyopathy, but they don't have obstruction. Here is an example of a heart that has a disproportionate thickening of this part of the septal muscle, and the outflow tract, which is right here. This is how blood exits the left ventricle. That area is obstructed, and this constitutes a form of hypertrophic obstructive cardiomyopathy that may be amenable to surgical treatment and myectomy. But the other thing this slide points out is that there are many different forms of the obstructive type. And, not all of them are as common as some. And the form that is perhaps most lends itself best to surgical myectomy is this form up here at the top, where the obstruction is immediately beneath the aortic valve. But there are many different forms of obstructive, hypertrophic obstructive cardiomyopathy. And that's pointed out in this slide, which shows you these different variants. Now, this is a MRI of a patient that has hypertrophic cardiomyopathy. This is a patient that ultimately was treated with myectomy. And again, blood enters the left ventricle through this flapper here, which is the mitral valve. And then the heart squeezes and blood is pushed through the outflow tract. Can you guys see my pointer? I'm trying to point to things as I speak. Can you see the pointer, the little hand?
Yes, we can.
Good. So this is the outflow tract, and blood is pushed out of the left ventricle into the aorta. And here you see this bulge of septal muscle, and it is obstructing this area. But importantly, that obstruction occurs between the septal muscle and the front part of the mitral valve. And so it's like a tunnel where the top is the muscle, and the bottom of the tunnel is the front part of the mitral valve. And myectomy consists of a surgical procedure in which we go in the chest and we stop the heart, and we very precisely remove some of this muscle to open up this area. So I know medications are much more, a medication is a much simpler thing than having to go through surgery where your chest has to be entered and your heart has to be stopped. But one thing I tell patients is myectomy, this surgical treatment that I'm trying to describe, it's a very focused treatment, and it really is focused exactly on the problem. The problem here is symptoms related to this site of obstruction, and the myectomy is very focal. We remove muscle exactly at this site and alleviate the obstruction. And I find that, rewarding and understandable and pretty definitive. When we talk about medications, obviously you have to take medications, and they can affect anything in your body. They can affect the entire heart. And a lot of times they can have off-target effects. And, so one of the benefits of surgical intervention is that it is extremely targeted, and it's pretty definitive in terms of alleviating the obstruction and alleviating the symptoms that come with the obstruction. And of course, if medical therapies are effective, a patient would not qualify for myectomy. It's mainly patients that have significant symptoms, life-limiting, symptoms, which have not responded, significantly to medical therapy. This is an illustration. Most myectomies, again, address this muscle that is beneath the aortic valve. So the most common surgical approach is to stop the heart, open the aorta, and then work through the aortic valve. This is the aortic valve at the base of the aorta. And on the other side of this valve is that muscle that is thickened. And so the heart is stopped, the aorta is opened, and we go through the valve to resect that muscle. I also point out that the MRI is a very, very good roadmap. It is very precise in letting us know exactly where the muscle needs to be resected. And it is a diagnostic test that I really want on any patient who is going to undergo this surgery, because it really provides guidance as to where to resect the heart muscle. This further illustrates the working through the aortic valve. This red stuff here is meant to illustrate the thickened muscle. It's on the roof of the outflow tract. On the floor of the outflow tract is illustrated here. This white thing is the mitral valve. And so we want to, it is those two things that are pushed together that create obstruction. And frequently there's scarring in between those two things. And the mitral valve can be scarred, but the muscle can also be scarred. And this white line on this piece of tissue that's being removed is to illustrate where there is repeated contact between the mitral valve and the heart muscle when the heart contracts and when the obstruction is created. Now, one of the most common questions that I'm asked as I speak to patients about myectomy is, well, will the heart muscle grow back, and will I have to have this again? And I don't believe that the heart muscle grows back. Heart muscle does not regenerate. But there are patients, unfortunately, who will have had two myectomy procedures. And usually in that instance, it is related to the fact that although the surgeon removed muscle, they didn't remove enough muscle, and there was a persistent site of obstruction even after the muscle was removed. And that's kind of illustrated in this diagram of the heart. Here's the aortic valve. Here's the septum that's thickened. This is the outflow tract that becomes obstructed and leads to symptoms. The surgeon here has removed this ellipse of tissue, which is denoted by the dotted white line. And you can see that begins to open up this outflow tract, but you can see farther into the ventricle, there's still thickened muscle, and you can imagine that there can still be obstruction between the mitral valve and this residual muscle. So the observation that some patients were not being completely rid of the obstruction has led surgeons to make an effort to do a more extended resection after this initial resection. And that extended resection is directed more towards the apex of the left ventricle in this direction. And so if the resection, though, is done properly and extended, the chances of needing myectomy again are very, very small, and the obstruction in the outflow tract should be, fully addressed and definitively addressed. Now, this is another patient, and this patient also has obstruction, but it is placed differently than the first patient that I showed you. And you'll notice that this patient's MRI is not quite as nice as the first MRI I showed. And that, I believe that's because this patient has a defibrillator, and the defibrillator messes up the image a little bit. But again, this chamber is the left ventricle, blood is entering through the mitral valve flapper here, and then the heart is trying to push the blood out through the aortic valve, which is up here into the aorta. And you can see that this area right here that was, that we've been talking about, the outflow tract, really is fairly open. But if you follow down and watch when the heart contracts, you can see that in this patient, there is contact or obstruction occurring more in the middle of the left ventricular chamber. And so this is a variant, and it's an uncommon variant, but it has caused really obstruction to the middle of the left ventricle. And this patient actually has developed, an area of almost an aneurysm at the apex, and that probably has to do with increased pressure that's occurring there. And this poor gentleman even developed some clots in the aneurysm. So this is uncommon, but this patient had ventricular arrhythmia problems as well, but this patient had symptoms, and it was related not to really obstruction of the outflow tract, but obstruction occurring deeper in the ventricle. And in general, down here, it's much more difficult to approach this site through the aortic valve. So in cases like this, the approach can be through the apex. And so this aneurysm can be opened, clot can be removed, and through the aneurysm, we can resect and get at this muscle here and alleviate the obstruction, which is really occurring in a deeper location. And this is an actual heart, and this is an incision that has been made in the apex, and it is addressing an obstruction that is more in the middle of the chamber. And you can begin to see that this area down here is the septum, and this area is a scarred lateral wall, but it's also scarring on the base of the papillary muscle. So in this instance, this site of obstruction can be addressed through the apex, and this muscle can be shaved here so as to alleviate this obstruction, which is again in the middle of the left ventricle, not really approachable through the aortic valve. This further illustrates a patient that had the aneurysm feature that I showed in the MRI, and you can see that out here at where the apical incision was made, the ventricle is very thin, and this heart muscle has turned to scar because it's been subjected to very high pressures, and this bulging or aneurysm has formed a very thinned wall. So there are many different flavors or types of hypertrophic obstructive cardiomyopathy, and patients who have this mid-ventricular obstruction are less common, but we think that they can respond to surgical treatment with a myectomy from a slightly different approach. So what should patients expect? Well, again, the point of this is to help patients feel better, be able to be more active and functional. And we say they have, it is to reduce their symptom burden. And the vast majority of patients with this very focused surgical treatment will experience substantial improvement in symptoms. Patients are able to reduce some of the oral medical treatments. However, there are other issues and other things to think about with hypertrophic cardiomyopathy. One is ventricular arrhythmias, and Dr. Dober is going to talk about this a little bit more, but it's not clear that myectomy impacts the incidence of ventricular arrhythmias or treats that component. And it's also, unclear whether myectomy or how myectomy impacts survival. Some patients with hypertrophic cardiomyopathy probably have a normal life expectancy, and myectomy isn't going to make that normal life expectancy any better. Some have an impaired life expectancy, reduced life expectancy, and we still need more information about whether myectomy is impacting the life expectancy. So I will, I'm going to keep my presentation brief, but again, I'm privileged to be able to participate in this webinar, and I really admire the Hypertrophic Cardiomyopathy Association. So thank you for letting me be a part of this tonight.
Well, thank you for taking some time with us this evening. We truly appreciate it. We have a question for you from Linda. She wants to know how much of the septum is removed in grams during a myectomy, and how do you know if you get enough muscle out, being that this is mostly a blind procedure and you're going by feel? So how do we know you have enough? And what is the average amount of tissue removed?
Different surgeons approach this differently, but I weigh the specimen. I try to set a goal or a target for the number of grams of heart muscle that is resected based on the appearance of the MRI. Now, the MRI doesn't give me weight, but we do know that a cubic millimeter of heart muscle or a cubic centimeter of heart muscle weighs approximately a gram. So when we see, when we think about the type of volume we want to remove based on the MRI, we can predict the number of grams that we're going to remove. So I would like to think of this not as a blind procedure. I'd like to think of it as, with MRI imaging, we can make this quite calculated. And with experience, we can relate what we're seeing in the ventricle to the MRI image and be pretty focused with the resection, and also have a pretty important, have a reasonable goal of how many grams we're going to remove.
Thank you. We have a few more questions. So next question is, what is the average recovery time for a myectomy?
A good question. Usually patients will stay in the hospital about 5 days. The first day is in the intensive care unit. Usually the remaining days are on a step-down ward. When they go home, they will still have some soreness, and they may need, pain medication, narcotic pills for a week or two periodically. I see patients back in a couple of weeks, and usually they're pretty active. But complete recovery probably takes a month or two. And certainly if your employment is more physical, you should at least think about 2 months off from your employment.
So interestingly, I spoke to a young man early this week who is under the age of 35 and had a myectomy, and was trying to get back to work, but he was getting some pushback from a local cardiologist that he should, wait and go all the way through cardiac rehab. He's about 8 weeks out of surgery now. What do you think the role is for cardiac rehab in a young patient with HCM? Is it a requirement? Is it a suggestion? When should it be used?
We deal with this a lot. I think of cardiac rehab as just aerobic activity with a cardiac monitor with monitoring the ECG. I think it's a very good idea for any patient that's had heart surgery, or for that matter, any major heart intervention. It's graded increase in aerobic activity with cardiac rhythm monitoring. I think it's a great idea. I recommend it for all my patients.
Fantastic. Yep. Okay. So we have 2 more questions. The mavacamten question I'm going to hold to the end because it's really a little off target here. But Chels is wondering, how long is a patient on the ventilator during surgery and after surgery? When do they come off the vent?
Most cardiac surgery, including surgical myectomy, we keep patients on a ventilator for a few hours after completion of the surgery as a safety precaution. So if you have your surgery first thing in the morning, the surgery will probably be completed by, say, 11 o'clock. And in our institution, you'd go to an intensive care unit still sedated on a ventilator. And about 3 or 4 hours after the procedure, if everything is stable, the anesthetic is decreased and stopped, and you're taken off the ventilator. So it's 3 or 4 hours beyond the end of the procedure is a common duration of being on the ventilator.
I have been there. It's not fun, but it's definitely doable. So you can not worry so much about it. It sounds a lot scarier than it is. So we're going to move on to our next talk now. And we're going to talk about something, pun intended, near and dear to both of my hearts. And that is advanced heart failure and transplant in HCM. And Adam is going to walk us through the approach of advanced heart failure at Duke. So take it away, Adam. One of my favorite names, my husband's name.
Great. Well, thank you, Lisa. I appreciate it. And thank you, everybody, for joining and for the opportunity to speak. Thank you, Linda, for asking the question about how much do you remove. I did not know Dr. Milano weighs it in the OR when he does a myectomy. So thank you. I didn't know that. So I am going to talk about advanced heart failure therapies, and I have a couple goals I want to achieve here for the next 10 to 15 minutes. So one is just to kind of recognize that the last hour or so has been around all the different advancements that are going on in hypertrophic cardiomyopathy. And because of that, more patients are living longer and longer with this. And so a lot more patients will, live for decades with this and may need to be considered for advanced heart failure intervention. So it's kind of one of the downstream consequences of all the successes that we're having. I want to try to introduce what is new in advanced heart failure. I'll talk a little bit about left ventricular assist devices and then a lot more about transplant, and then try to introduce you to our program. I'm really proud of our advanced heart failure program. We are definitely trying to provide successful therapies to as many people in need as possible. And I want to tell you how we're doing that, specifically around transplant. Like the other speakers, I want to share a case. So this is a patient that we followed in Duke Heart for many decades. He's now 52. He was diagnosed with hypertrophic cardiomyopathy at age 25. And when he was first diagnosed, he had a ejection fraction of 55%. He had obstructive symptoms like Dr. Milano was talking about. He was active as a landscaper and ran his own business, and followed with Dr. Wong in the Duke Heart Clinic with the hypertrophic cardiomyopathy clinic, and did well for a while, was on different medical therapies for his symptoms. But around 2020, so many decades later, he developed recurrent atrial arrhythmias and was in and out of the hospital for management of those, as well as cardiogenic shock. And his ejection fraction was starting to drop. It was down to 35 to 40% over some of those different hospital stays. And a few years later, he ended up on IV continuous milrinone to manage his symptoms and to try to keep him out of the hospital. And that's around the time that I met him. So given the fact that he was needing a continuous IV medicine, we started to talk about transplant for him. He'd been living with this for many decades, but I still think he took it as a bit of a surprise. We were able to get him evaluated and listed for transplant a little bit like a year and a half ago. And he was transplanted 8 days after being listed by Dr. Milano and did really well. Was discharged about 2 weeks later, and he is doing great after transplant. He's now back to work, running his landscaping business and really thriving. And I'm going to try to tell a little bit more about his story as we go through some of these slides. So I think one of the most common questions I get is, when do you start to think about advanced heart failure therapies, in general, but also for patients with hypertrophic cardiomyopathy? And I want to try to answer that two ways. So one, if you kind of think about that red graph across the bottom here, I think people, regardless of their heart failure condition, will have ups and downs. That's been one of the themes we've already heard people talk about. And I really feel strongly that my job is to try to meet them as early as I can in the course of their disease, but to try to recognize when I think things are getting worse over time and when they might benefit from surgery. And a part of that is not just to try to, get them to surgery at the right time, but also when they can do well afterwards and thrive after the surgery. So some of the reasons that might be triggers for that is, one, like the patient example that we used, requiring ongoing hospital care, being stuck on IV medicines or different devices. That's really one of the most obvious reasons when we start to think about transplant. The other is just, if I'm following somebody in clinic, I'm seeing them frequently, we're doing testing, whether it be cardiopulmonary exercise testing or lab testing, maybe right heart caths, and we're seeing some numbers that are changing that are making me nervous that they're at a higher risk of dying. And that's another time when we might say, like, I really think we've been talking about transplant for years. Now it's time to move that up. The third is probably less common, but it still does happen, is when a patient's living with the condition. I think they're sick enough to be talking about transplant, but it's not quite the right time. But they're starting to think, their life is being impacted more and more by their illness, and they want to try to push things forward. And a good example of that might be like if they're having more and more arrhythmias and ICD shocks, and Dr. Daubert and his team, aren't able to offer anything outside of another ablation or medicines, and really the next step would be transplant. So those are the most common reasons why we might talk about transplantation. I mentioned I did want to talk a little bit about left ventricular assist devices. This is a really important success story in my field. If you look across the slide from left to right, really a short while ago, 15 years ago, we were using very large pumps that had high complication rates, and people still derive benefit from them, but they often were left with challenges down the line of either thrombus in the pumps or strokes. And it's really been just a marvel of technology. If you look at the HeartMate 3 all the way on the right, of how patients are doing now. So this is our most contemporary pump. People are supported well with it and can live a good life with it. But the complication rate is much lower. And specifically, even as recently as the American Heart Association meeting, we're seeing data coming out with very low stroke complication rates, very low rates of thrombus in the pump. And this is just a really big advancement for our field, that people are able to live and not have complications with the devices. But, Dr. Milano kind of already alluded to this. There are lots of different morphologies in patients with hypertrophic cardiomyopathy, and we put these pumps in the left ventricular apex here. And so really, this isn't a very common intervention for people with hypertrophic cardiomyopathy. We really need the heart to be more dilated for this to work, but sometimes it's being considered. A much more common intervention would be transplantation, and that's what I'll spend really the rest of my time talking about. And I think the good news is that for patients with hypertrophic cardiomyopathy, they go on for transplant, they do really well. Their outcomes are just as good as patients who are transplanted for other reasons, like non-ischemic cardiomyopathies or for coronary disease. And so a really important question is like, well, what's new in transplantation? And there are lots of things going on, certainly xenotransplant. Pig hearts is one of the biggest topics. But if you really look at like what's moving the field over the last few years, it's different changes to procurement technologies, meaning how we are able to transport the heart from the donor hospital back to Duke to be able to do the transplantation. And it was as recent as like 2015 that the standard for that was a cooler, just like you're used to for your family picnics, and bags of ice is how that used to be done. And a lot has changed in this space in a very short amount of time. I included a picture of just, one other technology that can be used for procurement modalities. So this is the TransMedics organ care system, where the heart is able to be oxygenated. Blood is perfused through the heart while the heart is being traveled from hospital to hospital. But there are other systems too. There are more sophisticated cooling systems that allow for a uniform cooling around the heart so that there are no areas that are colder than others, and for lack of a better explanation, kind of prevent freezer burn. There are also newer technologies that allow for cold perfusion, so the heart can be cooled but still perfused at the same time. So there's just a lot happening in this space. And what all these different technologies allow is for larger and larger donor pools, and I'll give you an example of that. Again, really just, when I was starting out in this field, like as recent as 2015, when we were talking about how to do a heart transplant and where to try to find donors, we knew that the longer the heart stayed out of the body, the more likely that heart was not going to start up normally when it was put into our recipients. And so we tried to keep that total time down to about 4 hours. But if you factor in, getting from the hospital to the airport and then getting from the Raleigh airport back to Durham. What that really translated to was we had to keep flight time to about 75 minutes to keep the whole travel time less than 4 hours. So, we could look for donors kind of within this circle range here. And we were able to help a lot of people with that. That worked out well. There are a lot of potential donors in this area. But with these newer technologies, we could draw from anywhere in the United States, Puerto Rico, parts of Canada. And so we're no longer limited. You can just imagine how many more potential donors we have now for our recipients in North Carolina. And sometimes that means, like, if we have a challenge with immune matches, we might be able to find them there. Or the other part that this translates to is it often means we can offer transplant when a patient needs us, like the case vignette that I shared with you. He's transplanted 8 days after listing. Hopefully that means that he's being transplanted. He's not waiting for a long time on the list, getting sicker and sicker and sicker. And so hopefully he gets transplanted, can recover quickly afterwards and go home and thrive. The other part that some of this technology allows for is the use of DCD donors, or donation after circulatory death. So there are lots of people who have neurologic injuries, and the family would like to donate organs. They think that's consistent with their loved one's wishes, but the donor hasn't been declared brain dead. That's a medical and legal definition. So the family will go ahead and withdraw care. The potential donor would pass away. But some of these technologies allow us to still use that heart if we're able to procure it quickly after the donor passes away and it starts up normally in one of these systems. We can still use it for transplant. And our center, along with many others, have shown in randomized trials that those hearts that are used and from donors who died after circulatory death, those hearts work just as well as hearts that are used after traditional brain death. This was published earlier this year. It's this, really big changes in the field. And I think this is really kind of the next frontier in transplantation right now. So all this is translated to a lot of great things at Duke Heart. We have grown year over year since 2015, and including this year, we'll grow again compared with last year. But last year, we became the largest transplant center in the United States. We're very proud of that. It's been a very exciting time for us. And I think it's translated to a lot of great things for our patients. So you can see our survival is shown in the bottom left. The Duke blue are us, compared to the rest of the country. And then you get a sense of how this also translates for waitlist time for our patients. When we invest in programs like those I was talking about, we have much shorter waitlist times than the other hospitals in our region or across the rest of the United States. And again, I think that translates into better post-operative outcomes for our patients, because hopefully they're not as sick when they're being transplanted. So, we were kind of asked to talk about what we're passionate about. This has been a lot of fun for me, and being a part of a lot of these new innovative things at Duke Heart has been a great experience for me. And we've done a lot of first things. So a lot of these first transplants have happened in adults, but a lot of this has also happened in our pediatric program. So a lot of the DCD work has also been translated to help children. And a lot of other really exciting things our pediatric program has been doing. So I'm looking forward to the Q&A, and hope you have some questions for me. I also have my email address on here if you have questions for after the presentation as well.
We do have a couple of questions popping up for you, and I have the first one.
Great.
When you say largest transplant program, is that heart, is that kidney, is that combined? Give us some idea of where we're at.
Sorry, this is the largest heart transplant program.
And how many hearts did you do in the past year?
We did 143 last year, and there are 2 happening right now, so we'll be at 140 today.
There are 2 happening right now.
Yes, Dr. Milano's 2 colleagues are both doing a transplant. Yes.
I find that so cool. So as we all know, I'm a transplant recipient. So as I said, this is a matter near to both of my hearts. And I think there's a lot of fear around transplant. If we feared a surgeon to begin with, we fear the T word even more, because it's a pretty rough one. So the ability to transfer hearts a further distance, are we seeing any negative consequences of having the hearts out of the body this long?
That's a great question. And, in our field, I think Andrew started this night off by talking about lack of evidence, and in our field, we are hamstrung by that a little bit because there's not a lot of incentives to participate in clinical research in heart transplant. The numbers are small, and lots of other reasons why people don't participate in research. But for this, we have randomized trial data. We've got clear evidence that the hearts work just as well, which means these are ways that we've shown that you can grow the donor pool, find donors that otherwise wouldn't have been used, and have the same outcomes. And so we've got good evidence to support this practice. There are other consequences. So, like the cost of the procedure goes up, like the procurement costs. It's more complicated to try to coordinate a transplant from California than it is from down the street in North Carolina. So there are other trade-offs, but those are things we're willing to do for our patients.
Wonderful. Okay. So we do have a couple of other questions here. Is there an age limit now for receiving to be listed for transplant?
There are some institutions, a common one is 65 or 70, but there's no national age cutoff. We don't have a specific age cutoff at Duke. Something I'll say often to patients is that there is some age in all of us where the risks of immunosuppression start to become greater than the benefits of the transplant. I don't know what that is in each individual patient, but when I'm sitting with an older patient talking about the risks and benefits of transplant, that's usually what I'm talking about, is like, what's life like on immunosuppression for you if you're 75 years old? And I
There was
think
a really great poster at AHA from the NYU group that because this is a poster, it's not published yet, but because older patients have a less active immune system because of age, they are seeing that the older patients may require less immunosuppression, they're thinking. What do you think about that?
Yeah, I think, if I had another 10 minutes, I think the other big thing that's happening in heart transplant is our ability to monitor the immune system non-invasively. So cell-free DNA is really a game changer for us, where we don't have to go biopsy somebody all of the time. And I think that's going to allow more tailored immunosuppression. Are you showing your IJ? Yes.
Yes, I have a neck that's quite scarred from such endeavors. And
yes, I think there'll be less and less of that over time. But I think we also can fine tune immunosuppression for patients as we get better with it. This is a newer technology, but I think something like that being suggested is probably true, and we could probably show that over time.
so somebody's asking a question about immunosuppression following transplant. It's forever. And just kind of address that we're looking at ways to better measure. So maybe we can not suppress so much, and maybe we can customize per patient. So do you see anything new coming in immunosuppression following transplant?
Well, there's nothing specific for heart transplant, but there are so many new targeted biologic agents that I do think they will find a home in solid organ transplant. What I mean by that is, like, part of the, when you went through biopsies, we are looking at one very specific thing, like the presence of immune cells in heart tissue. And that's great. And that tells us something about what's going on in the heart. But if we're doing biologic assays of your immune system, we're learning a lot more about what's going on with your immune system throughout your entire body. And I think because of that, we'll be more comfortable using targeted therapies, like things that are developed for rheumatoid arthritis and Crohn's disease and so forth. I think those will follow in suit. So I don't think there are going to be new drugs that are specifically for heart transplant. There's nothing, the latest and greatest right now. But I think we're going to have a better understanding of the non-invasive immune system and feel comfortable trying to target things.
So another question is, this is always one that's difficult to ask. Average lifespan post-transplant for an HCM patient, not all comers. What do we know?
Yep. So again, just as good as patients transplanted for other reasons. So outcomes are very good. One of the challenges is if you type that into Google, you'll find this like 11 or 12-year median life expectancy, which I find to be a very frustrating statistic that I spend a lot of time trying to dispel. Those are often, median values of transplant centers or nationally, but that doesn't tell us anything about like a conditional life expectancy for a patient. And so we expect it to be very long. A lot of it's driven by your age at transplant. So if I transplant a 75-year-old, they're not going to live to be 110. But younger people, we expect them to do really well.
So I always bring up my hero, Claude Brady, first patient ever diagnosed with HCM in 1959, transplanted in 1988, passing away in January of 22. So he made a nice long run with that donor heart. They were good friends for a long time. And I know many patients with HCM who are in the late teens to early 20-year post-transplant, and they were transplanted young and they are doing well. So we know that there can be a long life after transplant. So Mary's posting that her son's heart failure team says transplant's a last resort. You're exchanging one set of problems for another, but the future is bright for transplant patients today. We've learned so much. We've come so far. I didn't think I'd be feeling this great almost 7 years out, and I feel like I just kind of got started. So what do you think about long-term survival?
Yeah, and I'm going to address one thing it says in there of trading one illness for another. I don't like that phrase very much, and I'll tell you why. I think there is risk of the surgery. It's real. There are a lot of it's a very complex thing we're trying to do there, and there are consequences of the immunosuppression that are important. And so we don't want to take it lightly. We want to make sure that the risks are appropriate when a patient does get recommended for transplant. But at the same time, I think most people do really well, and the challenges of living with a heart transplant are things that we can manage, and they're things that we help guide people through every day in clinic and with phone calls and stuff, and it's all stuff people can manage. So there are challenges with it, but I wouldn't call it trading one illness for another, which is a common phrase. So I'm sure
As somebody living with a transplant, I will say you exchange living with a disease for living with some other things that are manageable. I just was at AHA in Philadelphia this past weekend, and 8 years ago, no, I didn't go 7 years ago, 8 years ago, when I attended AHA, I did it in a scooter because I couldn't walk the floor. And as I was standing in the booth this Saturday, I looked out and I saw somebody going by in a scooter. And I did 20,000 steps on Saturday. And when I have those moments, I almost cry because it's almost unbelievable that I was that sick and have gotten this much better. And there's a lot of hope for those with transplant, but we know it's challenging. That's why we run the transplant pathway discussion group once a month to talk about it. It's different living with somebody else's heart. There's some psychological and emotional issues that we deal with regularly, but we talk about them and it's okay. And I just don't want people to be afraid of the T word. I was afraid of the T word for a long time, but it's not so scary and it's very doable under the right circumstances. So don't be afraid if somebody brings up transplant. It's something we can do together. Okay, we're going to move on to our next talk. And I think we're bringing Jim Daubert up now. Absolutely. Here we go. And we're going to talk a little bit about devices and sudden cardiac arrest risk assessment. And we've got your reading is up there, but not your slides yet. And thanks for joining us tonight. Yeah. We'll get your slides up, make sure you're good to go, and then we will hand it off to you. Yep. And if you have questions that have been culminating throughout the evening, I would encourage you to start keying them in shortly. And we're going to now hear from Dr. Daubert. Thank you.
Okay, Lisa, do I have the right screen up?
You have the right screen up and you're ready to go.
Excellent. Well, thank you, Lisa, and to the HCMA team for organizing this and for the patients, family members, et cetera, who have joined. I certainly have enjoyed the talk of my colleagues and hope it's been informative for everyone. And I'm going to talk about arrhythmias that are a common part of hypertrophic cardiomyopathy, how we can identify them and manage them. So I'm a member of the Duke team here in the Hypertrophic Cardiomyopathy Center, and also involved with cardiovascular genetics, sports cardiology, and electrophysiology. So what are the common serious arrhythmias in hypertrophic cardiomyopathy? What do we mean by these different arrhythmias? So ventricular arrhythmias on the left, ventricular tachycardia, ventricular fibrillation. What is ventricular tachycardia? Here is a tracing from the atrium of a patient, actually with a defibrillator, and here is the ventricular channel. Notice there are more V's than A's, we call it. The ventricular rate is faster than the atrial rate, and the ventricular rate here is going about 180 beats a minute. So this is a regular ventricular tachycardia. Down the bottom, a much more disorganized rhythm. This is ventricular fibrillation. And these are both patients with hypertrophic cardiomyopathy. Over on the right is a patient with HCM with atrial fibrillation. Here's the atrial channel here. And notice how fast and disorganized this atrial channel is. Sort of similar to the ventricular surface channel here over in ventricular fibrillation. And in this case, the atrial arrhythmia is conducted to the ventricle so fast that it's led to a shock by the defibrillator, which is something we try to avoid happening. But this was indeed very fast. So those are the common arrhythmias that we'll be touching on today. And so first we'll talk about ventricular arrhythmias and sudden death. And how can we predict sudden death and thereby prevent it? Well, we know that patients with HCM are at increased risk of sudden death, but it's not an equal risk for all HCM patients. We can identify risk factors. They're listed here, and these include family history of sudden death with some caveats to the right, extreme left ventricular hypertrophy, around about 30 millimeters of thickness of any segment of the left ventricle. Unexplained recent syncope, passing out. That puts someone at higher risk of sudden death. Why? Because that passing out might have been a ventricular tachycardia that terminated. Identifying non-sustained ventricular tachycardia is a risk factor. A large, significant amount of scarring or fibrosis seen on an MRI is a risk factor. Having a reduced ejection fraction, usually the ejection fraction is hyperdynamic in HCM. And when the ejection fraction declines, that's a red flag, a warning signal. So is having an aneurysm in the setting of apical hypertrophic cardiomyopathy. So this is these are the guidelines for HCM published several years ago. And you can see that a prior event, sudden death, ventricular fibrillation, sustained VT, that's a class 1 indication for an ICD. If we come down to these risk factors we just talked about, if any one of those is present, then we have a class 2A indication. Green, yellow, red, orange, red indicates how strong or absent in red the indication for a defibrillator is. So this is 2A, meaning it's an appropriate discussion. It's appropriate to implant it, but some patients will say, okay, I hear you, but no thanks. I'm not convinced yet. Non-sustained VT is listed a little bit separately, a little bit lower of a risk factor than these others here, except in children, where it is as high a risk, as important a risk factor. And then extensive scarring on LG, late gadolinium enhancement on MR is more of a tiebreaker kind of a risk factor. If none of those are present, then generally an ICD is not indicated. Now, when we're thinking about risk of sudden death and leading to a decision to put in a defibrillator, we have to balance that with how likely the patient is to have an arrhythmia and need the defibrillator versus have the defibrillator and potentially have complications from it. So this is data from one center where the appropriate ICD event rate, shocks or pacing from the device, was 3% per year. The ICD complication rate was 2% per year. Those included inappropriate ICD shocks like what we just saw for atrial fibrillation, infection, lead fractures. There are several ways of gauging the indication for an ICD. We looked at the ACC-AHA guidelines a moment ago. The European Society of Cardiology has put out kind of overlapping but different guidelines. If you only looked at the high-risk patients in the ESC criteria, you would miss some patients who would have sudden death. So you'd put in less defibrillators in the population, but you'd miss some patients who are going to have a serious arrhythmia and potentially pass away. And as I said, we don't want to put defibrillators in patients very unlikely to ever use them, need them, because they're at risk of having the complications as well. So it's a trade-off. So when we're talking about defibrillators, what do we mean? This is a transvenous defibrillator. There are one or more wires, leads we call them, that go in through a vein, transvenous, that means through a vein, down into the heart. So here's the lead in the right ventricle. This particular device has 3 leads, a left ventricular lead and an atrial lead as well. But at a minimum, there would be 1 lead in the right ventricle. On the left here, though, is shown a subcutaneous ICD. The lead, you'll notice, is here. It's not in the heart. It's in the subcutaneous tissues, right above the sternum, the breastbone. And then the lead is connected to the defibrillator that's also sitting outside the chest, over on the left lateral region, not up here in the front of the chest like a transvenous defibrillator. There are pros and cons of these different devices, but in this study of patients with hypertrophic cardiomyopathy having either device, there's a suggestion there may be fewer inappropriate therapies and similar but not increased risk of complications with the subcutaneous defibrillator. Now, if one needs a pacemaker, the only choice is transvenous. But if there's no indication for pacing at all, no slow rhythms, no need for cardiac resynchronization or biventricular pacing, then a subcutaneous defibrillator might be an option. And this has been looked at from the patient's perspective, and really the patient quality of life is similar for the 2 types of devices. Well, there is some work going on. So we looked at, identifying patients at risk of sudden death. And I've indicated that we're not perfect at that. We put in some defibrillators. The patients may never go on and have an arrhythmia, never need the defibrillator. And, we kind of talk about that as having an insurance policy you don't need. But if we really knew the patient wasn't going to need it, we wouldn't implant that defibrillator. There's some exciting work ongoing that looks at importing the MRI, the electrical characteristics of the cells, trying to get a 3-dimensional characterization, look at the electrical activation in the heart. And there have been other studies, I'll just mention parenthetically, that have looked at electrical activation in the heart. We talk about myocyte, heart cell disarray. The heart cells not organized as uniformly as they should be. That leads to abnormal activation of the heart. So if we can put all of that information, the fibrosis, the abnormal activation, and the thickness and other factors in, we may be able to identify whether the patient's at risk for reentrant arrhythmias that lead to those ventricular tachycardias and fibrillations. So there is hope for the future to be more targeted and better understand these factors. So I'm going to switch over to atrial fibrillation now. And what do the guidelines say about managing atrial fibrillation? So in patients with hypertrophic cardiomyopathy and clinical atrial fibrillation, anticoagulation, a blood thinner, is recommended with direct-acting oral anticoagulants as a first-line option, or vitamin K antagonists like Coumadin or warfarin as a second-line option. and this is important, independent of the CHADS VAS score. This is what we use to decide who needs anticoagulation for other patients with atrial fibrillation. But if you have hypertrophic cardiomyopathy, you're at high enough risk of stroke that you should be on an anticoagulant. And here is which patients are indicated for an ablation. Those who have symptomatic atrial fibrillation are undergoing a rhythm control strategy. Ablation can be an effective option if medicines are ineffective, contraindicated, or if the patient prefers an ablation strategy over medications. Well, just like ventricular arrhythmias, can we predict which patients are going to get atrial fibrillation? And the answer is, to some degree, yes. We can look at age, at diagnosis, current age, left atrial size, more dilated, more AFib likelihood, heart failure symptoms, and come up with an HCM-AF score and put the patients into a different bin: low risk, intermediate risk, high risk, 2% a year or more, and monitor those patients more closely. There are still other things that could be looked at. We know frequent premature beats, runs of supraventricular tachycardia, characteristics on the electrocardiogram, the ECG P wave duration, other characteristics, left atrial volume, anatomy of the left atrium, and machine learning, or AI, that everyone's hearing so much about. These may be predictive of atrial fibrillation in the future. And why is atrial fibrillation important? Because it increases the risk of mortality by more than twofold in hypertrophic cardiomyopathy, similar really to other patients as well. Another study looked at this risk, predicting the risk of AFib in hypertrophic cardiomyopathy, used the MRI. And interestingly, the MRI was one of the factors, but here's body mass index. Having a higher body mass index predicts higher atrial fibrillation in general, and it does in atrial fibrillation. But notice it's really specific to certain age groups here. In your 50s, if you have an elevated BMI, it really splits out the risk of atrial fibrillation. On the other hand, the size of the left atrium comes into play at younger ages, 30s and 40s here. The left atrial contractile index, how well the left atrium squeezes, is most predictive more in the age of 50s and 60s. So interesting data here. And again, machine learning may help us understand that. There are studies on that factor. So here I'm going to close out with a little bit on ablation for atrial fibrillation in hypertrophic cardiomyopathy. And here's a study that looked at both HCM and non-HCM patients. And how did they do? So the HCM patients were 50 to 60 years, more males than females, and a mix of paroxysmal and persistent atrial fibrillation in these studies. For those who haven't seen what an atrial fibrillation ablation is, it involves placing catheters that are 2 to 3 millimeters wide, coming up from the vein in the leg, the femoral vein, up to the heart, crossing the atrial septum to get to the left atrium. These openings here are the pulmonary veins. Atrial fibrillation usually arises from in or right at the opening of those pulmonary veins, but not always. So those are the number one places that we ablate, around those pulmonary veins. So how do patients with HCM versus other patients do? And the answer is they have a higher risk of recurrence after ablation than other patients. Higher incidence of needing a second ablation. But here's some good news, that freedom from atrial arrhythmias after the last ablation, maybe they've needed a second ablation, can be as high as 82% freedom from atrial fibrillation. In other studies, it was more 50 to 55%. So a little bit higher risk of recurrence with HCM. Is that because the atrium is hypertrophied, thicker, harder to get a lesion all the way through the wall? Is it because they're more foci, more triggers outside of the pulmonary veins? Is it a combination of those two things? That's work in progress. It's been looked at a little bit, but we don't know all the answers there. So I'm going to wrap up there, and I'm happy to take any questions. And
You've
really
got some questions.
Good. Really appreciate your attention.
We can bring the rest of the crew back in as we'll do general questions after we conclude yours, so everybody can come back on screen and join the party. So a couple of questions. I have one first. There's a new ICD from Medtronic, the EV-ICD, which is a different approach to leads. Could you give our listeners and viewers some information on this new type of device and what we know about it so far?
Yeah, that's a great question, Lisa. Thanks. So it's let's think of it as something in between the transvenous and the subcutaneous ICD in terms of its level of invasiveness. The goal is to not have any leads inside the heart where an infection could cause a risk of infecting the heart valves and be much more serious. So this device puts the lead under the sternum on top of the heart. The sternum is what Dr. Milano opens up to get to the heart. So this would be in his way if he needed to do surgery, but the lead is being put under the sternum, under the breastbone. Why? So it can easily sense the heart signals there, can a little bit more easily shock the heart, maybe not need quite as much energy, and potentially provide the ability to pace the heart from the outside of it. Not quite as efficiently as if a wire were inside the heart, but potentially enabling anti-tachycardia pacing or bradycardia pacing. So it's relatively early. It's been studied. There are not a ton of implants. We've done one or two at Duke, and we're still relatively early in the learning curve of it. There is concern that putting the lead so close to the heart and other structures in the mediastinum, the chest there, could be risky, but so far in the study it's gone pretty well.
Okay, I find it a really interesting concept. I'm a little worried about the placement in case we need to do anything afterwards, but I guess if the surgeon goes in, they can move it and then put it back in place if need be. I'm sure they can figure that out. So we'll get to that. So we have a couple of questions from our viewers. How do you choose a brand of ICD, and what percentage breakdown is being used at Duke between the major manufacturers, which are Medtronic, Boston Scientific, Abbott, which used to be what Abbott used to be, St. Jude, and Biotronics. So what's the breakdown?
Yeah, we use mostly Medtronic and Boston Scientific. Those are among the biggest players in the United States. Biotronic is a German company originally, but they've made a nice presence in the United States. It's a little bit, there's a leapfrog situation. So one company would be ahead in one factor. Maybe it's the lead, maybe it's the battery, maybe it's the biventricular pacing lead, maybe it's most recent recalls, other factors like that. So there can be individual factors. For the most part, they're more similar than different, though, and some other factors like cost and contracts come into the play.
I'm glad you brought that up, because this comes down to a contracting issue, typically with the insurance providers and the institution and the device manufacturer. And sometimes those relationships are kind of behind the veil, and patients don't necessarily see which manufacturers are being used by which facilities. We wish that there was a way that we could have a little bit more transparency there. But I'm sure if a patient was interested in a particular feature from a particular manufacturer, and in collaboration with their chosen healthcare provider decided that that device was the right one for them, where there is a will, we would find a way to get that device in, I would assume.
And you're right, that brings up, even though we're trying to use a certain mix of devices if there's an important consideration, if a patient already has a given device, and especially if there's a research study involving a specific company and device, we absolutely insisted that that be fair game and open to us and our patients to optimize things.
Thank you. Post myectomy is an appropriate an ICD appropriate if VTAC is more prevalent if there's a risk of heart block with myectomy. So let's break this one down a little bit. So this is a combination surgeon and EP question. In the event that you do a myectomy and you develop heart block, which is actually quite rare to create heart block, you need to have a right bundle branch and a left bundle branch block, and we'd have to break all of the conduction from the top to the bottom of the heart, which is incredibly rare in a myectomy. But if that were to happen and somebody were pacer dependent and let's say a post-alcohol ablation, then moves to myectomy and then we block, when does the device get put in? If they think that there's a need for it, and is there more VTAC after a myectomy? So we'll start with EP and then we'll go to surgery for that one.
Okay, sure. I'll jump in first. So timing, can depend on the urgency of it, and if there's a need for pacing, if there's complete heart block like you were describing, Lisa, then the patient may need temporary pacing for a few days, and if the conduction system doesn't recover, then a permanent device would be implanted before hospital discharge, perhaps 5 days after surgery, something like that. It could very individualized though, and that could be a pacemaker. But if the patient has HCM and any other risk factors, then we might certainly go with a defibrillator in that situation. But you're right. After myectomy, it's uncommon. A left bundle branch block can occur with myectomy. With alcohol septal ablation, a right bundle branch block can occur, and so doing one then the other is problematic. But let me ask Dr. Milano to weigh in on the subject too, please.
Well, one thing that I want to clarify is, does myectomy predispose to ventricular arrhythmias? You mentioned that, and I kind of mentioned it too. And we don't have any evidence that myectomy increases ventricular arrhythmias. In the short term, going through cardiac surgery, there's adrenergic drive, and a lot of different rhythms can be increased transiently, like in the week or two after surgery. So there might be some evidence that immediately after surgery there might be some increased risk of all types of rhythm problems. But long term, I would think that a myectomy would reduce your chances of ventricular arrhythmia, because obstruction is associated with very high pressures in the ventricle. It's associated with something called ischemia and damage to the heart muscle, which we can see on MRI. And I think you alluded to that. So long term, alleviating obstruction, reducing the pressures that occur in the ventricle, will probably reduce scarring and injury to the heart muscle, which I would think over time would reduce the likelihood of ventricular arrhythmia. Having said that, there aren't good, randomized studies to show or prove that a myectomy reduces the risk of ventricular arrhythmias, and ventricular arrhythmias occur uncommonly, so it's something that's hard to study. I mean, the frequency of these events is fortunately very, very low, so it's hard to study that. But I think long term it probably helps. We haven't proven that yet.
Yeah, I'll agree with you for sure that the series in myectomy patients indicates a low risk. Does it completely eliminate the risk? Probably not. If we look at risk of obstruction, it's one of the factors that weighs into the European Society calculator, how much obstruction there is. So it's perhaps not as strong a risk as severe hypertrophy, syncope, or fainting, but it is a risk. So eliminating that risk, it makes sense that the patient would be at a little bit lower risk. On the other hand, alcohol ablation, there's been more worry that that could be an increased risk factor for arrhythmia, causing an infarct in the heart. And maybe that risk has been a little bit less in reality than what we've seen. Maybe you want to weigh in on that, Andrew.
Yeah, that's a great point. You know, MRI studies have shown that in patients who have had a myectomy, there's a very small amount of endocardial fibrosis from that myectomy. But in patients that have had an alcohol septal ablation, there's generally a transmural infarct in the basal septum region. And that, when we first started doing the procedure, was a concern for the long-term risk of ventricular arrhythmias. Thus far, there's no clear indication from only observational studies, because there's never been randomized studies between the two septal reduction therapies, but no evidence that ventricular arrhythmias is increased. There was a recent observational study from the Medicare data set comparing the two septal reduction therapies that was published last year, that showed that patients with who underwent alcohol septal ablation seem to have a higher rate of 2-year mortality compared to myectomy, but the mechanism of that is not clear. Patients who underwent alcohol septal ablation were older and potentially had more comorbidities, but that is unknown whether it was due to ventricular arrhythmia. So still a lot to be learned, and we hope to obviously understand this more.
I think that's really helpful. So going back to some EP questions first, and then we'll get everybody else into the equation here. After several ablations and AFib persists, if medications are no longer working, what are the options at that point for a patient?
Yeah, it's a important question, because as I indicated, the risk of recurrence is a little higher with HCM patients. So a repeat ablation can be necessary in some patients. What do we look for then? We look to see what the areas we ablated, did they hold? Or was there recovery of conduction, recovery of electrical conduction out of those pulmonary veins? Sometimes we may have ablated several dozen times around the pulmonary veins or more, and it's just one little area that's recovered and needs to be re-ablated. On the other hand, there could be need for more extensive ablation if there's more scar tissue there. So at some point, more catheter ablations becomes a diminishing yield, whether it's 2, whether it's 3, depending on the type of arrhythmias that are occurring. It could vary, certainly by the patient. When we say enough is enough, what else can be done? Surgical ablation, operating on the outside of the heart. Hybrid ablation, going in and operating from the pericardium, the outside of the heart, and touching up adjunctive ablation again from the inside, from the endocardium, is an option. Exploring all the medication options, re-exploring them. They may work after ablation if they haven't worked before. And then probably we come to pacing, stimulating the ventricle and ablating the AV node. And important to think about the right type of pacing. Do we pace both ventricles, the His bundle, the left bundle, so as we don't reduce ventricular pumping function after that?
So the concern would be if somebody were to stay in atrial fibrillation for too long, that eventually the ventricle would get weak and we would drop an ejection fraction, and there we would cause advanced heart failure potentially.
Right.
That be a cascade that we'd be concerned about there?
Absolutely, especially if the ventricular rate, the heart rate is too fast in atrial fibrillation, as we saw in Andrew's case earlier.
Andrew, Adam, any comments on that?
I guess
I-
I would say there's a wide variability of how well atrial fibrillation is tolerated among all patients, but even in hypertrophic cardiomyopathy, there are some where even if the atrial fibrillation is well rate controlled, that loss of atrial mechanical function really leads to very severe impairment of quality of life and heart failure symptoms. There are other patients, for unclear reasons, where they can have permanent atrial fibrillation and really are not affected. Maybe it's based on their baseline functional status or how the ventricle is performing, but we see a very wide variety. And that's one of not only the challenges, but one of the really interesting aspects of HCM is trying to tailor the recommendation relative to the individual patient to try to make it as personalized as possible to say, look, you're in atrial fibrillation, but minimally symptomatic. We want to protect you against a stroke. Your rate is well controlled. But here's another patient, maybe even in the same family, who has atrial fibrillation, who is very symptomatic even during brief episodes of atrial fibrillation with good rate control. And for that patient, we would be as aggressive as possible to try to maintain normal rhythm.
So we had another question in there about AV nodal ablation that I didn't even see as we were going through the first one. So I think we kind of addressed that second question. Did anybody have any other comments they wanted to make on that area?
I was
No?
just going to remark that for patients who may be coming for surgery for myectomy, I think if they have had any history of atrial fibrillation, I think it's very reasonable to do an ablation at the same time as the myectomy. And I say that because I think we can perform the ablation quite safely. It adds very little additional time to the procedure. And I think those patients have some increased risk of having future atrial fibrillation. So that's something that I would ask about. Frequently, the patients have had some period of time on a monitor, and if they've had any atrial fibrillation on the monitor or any prior history, I would also do an ablation at the time of the myectomy.
Would you do a left apical appendage clip as well?
Yes, because
Okay.
I think that reduces stroke risk.
Fantastic. Okay, I think we've answered that question live. Couple of other questions, and we're coming into the final stretch here, ladies and gentlemen. The night is coming to an end. We're going to go back to Caitlin and ask a genetics question. And how would this scenario play out? My sister has HCM. My mother and father and I have normal, but my mother's brother, so my uncle, also has HCM. Can we discuss the difference between being genotype positive and clinically positive, or genotype unknown and being clinically positive? What's going on here?
Yeah, that's a really good question. I am curious, and I don't have to know to answer the question, just if genetic testing has happened in the viewer's family or not. But regardless, we would presume that this is coming from mom's side, that the genetic change, whether we know what it is or not, whether genetic testing found it or you've had it or not, is coming from mom's side of the family in this scenario that you described. It is really confusing, like you're telling me that your mother does not have any evidence of this of hypertrophic cardiomyopathy, and the reason that is this phenomenon called reduced penetrance, and it's something that we see in a lot of different inherited cardiac conditions, but a lot often in HCM as well. And what that means is not everybody that carries the predisposition or the genetic mutation for HCM will actually go on to develop the evidence of it or the disease itself. And we don't fully understand that. We think that there's, we think about HCM right now being caused by what we call single gene or monogenic, so a mutation on just one gene in somebody's body, like we talked about in the slides. And we think with reduced penetrance, there's lots of other players. So even if one family, 10 people carry that one genetic change, each individual person has a combination of genetics that's different from the other person, and that interacts with the environment in a different way. And so there's something happening in everybody's individual recipes that causes some people to develop the disease and some people to not. So a lot of words to say, it's most likely that whatever is being passed through your family, your mom would carry and just has not developed the disease itself. I don't know if that answered your question, or I know what you're trying to ask me, Lisa, but
I think that answers the question. If it didn't, I'm hoping the questioner can write back in.
yeah, I would
But I
love
think
to.
I think we've addressed it pretty well. Let's go to surgery for just a second. What kind of remodeling of the ventricle occurs post myectomy?
It's a good question. The thought would be that some degree of hypertrophy elsewhere in the ventricle is secondary to the obstruction, and relief of the obstruction may alleviate remote regions of hypertrophy. And I think I may have seen this in individual cases, but that isn't something that I don't tell patients to anticipate that. I think that it can happen, but it's hard to predict and who might experience that. So it isn't something that I put forward as something patients should anticipate. Again, the main benefit to the patient I try and discuss is how their symptoms are going to change.
Okay, I think that's a good answer. Now we're going to get into mavacamten and myosin inhibitors. So we have the first in class myosin inhibitor available as of April of 22. So there's probably now about 5,000 to 6,000 people in the world who are taking mavacamten for obstructive HCM with symptoms of class 2 or class 3 New York Heart Association heart failure, which we talked about a little earlier. Andrew, how do these things work? What is a myosin inhibitor, and why are they doing such amazing things in this community?
Thank you for the question. Patients with hypertrophic cardiomyopathy have been found to have hypercontractility, meaning that their muscle contracts to a greater degree with greater force than normal heart muscle cells. And what the cause of that is that there's actually increased interaction between two components of the sarcomere, the myosin and the actin. And the best analogy that I've heard, and I know Lisa has heard this too, it's like the number of hands on a rope pulling on something. And in patients with hypertrophic cardiomyopathy, there are more hands on the rope pulling, so there's a much greater force. And as a result of that, patients have a supernormal ejection fraction oftentimes. In the clinical trials of myosin inhibitors, patients had an ejection fraction of above 70%. Greater than 55 is considered normal. These patients are well above normal. And you would think that's great. You see patients who have heart failure, like, I want the highest ejection fraction possible. But there's a detriment to that. And the detriment to that is energy utilization and impaired relaxation and greater hypertrophy. And so myosin inhibitors block the activation of those myosin heads so that more hands on the rope are in the relaxed state. There are fewer hands pulling on the rope. And as a result of that, contractility is reduced. In the clinical trials of mavacamten, the reduction in left ventricular ejection fraction was about 4% or so on average. Some patients had a greater, some patients had less, but on average, 4%. But even that degree was associated with a much greater reduction in left ventricular outflow tract obstruction. I mean, like 70% reduction in left ventricular outflow tract obstruction or more. And I think you saw in the echocardiogram I showed earlier, the patient had a supernormal ejection fraction with a high outflow tract gradient. The ejection fraction was slightly worse on his current dose of mavacamten. There was still a little systolic anterior motion in the mitral valve, but really very little obstruction. So it's finding the dose that takes the right number of hands off of the rope, but you can't take all the hands off the rope.
No, we need some hands on the rope.
Yeah.
And we need to pull them back a little bit. So hands on the rope or oars in the water. So think about a rowboat versus a sculling ship. We want to be more like the rowboat and less like the sculling boat. So less oars, less power. And I think if we really think about myosin inhibition this way, there will be, potentially a second myosin inhibitor to market at some point in the near future. So there'll be some alternatives. And I know that the third and fourth are being thought about right now. So there's a lot of action here, and it's probably not just going to be good for HCM. It's probably going to be good for our heart failure with preserved ejection fraction friends, some of which may actually be HCMs, but we don't quite know yet. So there's going to be more room for these drugs in the future. Back to a surgical question. What are the risks of surgery?
I tell patients that the risks of major problems after surgical myectomy should be less than 1%. And what I include in major problems, one of the most important major problems is the creation of ventricular septal defect, where too much muscle has been taken and the surgeon creates a communication between the right and the left side, and then that has to be repaired, and it's difficult to repair. But other major problems would include things like stroke. There's a very small risk of stroke with any type of heart surgery. And in some of those pictures I showed, we work around the aortic valve and the mitral valve. And sometimes there can be primary problems with the aortic or the mitral valve, but there can also be injuries to the aortic or mitral valves. But again, all that stuff should be less than 1% at experienced centers.
So not that this isn't something that I have said about a million times before, but high volume matters, right? The higher the volume, the higher the experience of the selection for the patient, the higher skilled the surgeon is, the more myectomy is under their belt, the better the outcomes. Would this be a correct statement?
That's true of any type of cardiac surgery procedure. It's probably true of any type of technical medical procedure that we do.
Couldn't agree more. Are there potential downsides or problems to mavacamten with HCM? Can it make things worse?
So number one, just to reiterate what Lisa said, it's only approved for patients with symptomatic obstructive hypertrophic cardiomyopathy. It is not used and not approved, and we don't know if it's benefit at all in patients with non-obstructive hypertrophic cardiomyopathy or those who have a lower ejection fraction. The biggest risk and the reason why it is only used under a risk evaluation and mitigation program, meaning that a patient on the drug is monitored very carefully for any adverse effects with regard to reduced ejection fraction or potential drug-drug interactions or risk for a woman of childbearing age. Those are the biggest concerns about using cardiac myosin inhibitors. And not only is the physician prescriber responsible for undergoing training and awareness and basically pledging that they will monitor for these potential adverse side effects, but the patient actually has to be consented to say, I understand of these potential risks of being on a cardiac myosin inhibitor. I agree with, that I'll come back for the echocardiograms and notify my doctor if there's a change in my medication so that the doctor can check for drug-drug interaction. So it's a partnership going forward between the physician and the patient to say, look, we're going to work to get the best possible outcome from the use of this new drug, but in the safest way possible.
So you bring up a really good point there, that this is a shared decision and that there's responsibility on both sides. I'm going to give a personal perspective. That is, I truly believe that high volume HCM programs should be the ones managing myosin inhibitors as we're learning. It's early days. There's so much to learn. There goes the dog bark. We always get one of them. So congratulations to the dog owner.
That's mine.
Okay. So we knew we liked you, Andrew. You're a dog owner. You know, you gotta like a guy who has a dog. So we want to make sure that the way we're learning how to use these myosin inhibitors is with the opportunity of the comprehensive care team, with everybody on board, helping make that patient decision, helping the patient get through the process. We think it's really important in these early days of myosin inhibitors to be as safe as possible and to make sure that we're getting the right mindset, helping diagnose and manage.
And I would agree with not only that part about the longer term management of a patient who does want to be on it, but to talk about all the other treatment options there are. That's really the big question for shared decision making. And I have had patients decide on the different options for their treatment. Some have decided to sit tight, to say, okay, let's just see how this plays out a little bit longer. I have symptoms, but I'm not ready to commit to taking a drug indefinitely or to surgery or to alcohol septal ablation. But I've had, once you describe all the different options, I always believe the patient makes the choice that is right for them.
I would agree. So we've got 2 more questions. So if you have any other questions, this is the last call for questions. We're going to wrap up and let these nice people have an evening and maybe go eat some dinner or relax before they have to go to sleep and get up and do it all again tomorrow. So Caitlin, we're back to you with this question. The asker is actually a medical officer from Sri Lanka. So we didn't get them in the survey earlier. So they're out of the United States. So mother is negative for HCM on echo. Mother has had sinus bradycardia, pacemaker inserted. And he's going to reach out to you and maybe dig into this family history a little bit more, because I think we don't have good genetic information. We have clinical information. And I'm not sure what genetic screening is available to him in Sri Lanka. And maybe we can help him find some resources for that. So
yeah, definitely can contact me for sure.
Absolutely. So he'll follow up with that. And I left a complicated question for last. Chuck, you and I go back a long ways. I've known you for many, many years. He's got an ICD for sustained VTAC in the past and has been on amiodarone for 20 years. He's now developing some lung capacity decline, and they've tried flecainide and metoprolol, and the amnio was the only thing that controlled the VTAC. Being that his VTAC was 20 years ago, and he's been on amnio, excuse me, all this time, what do you do with somebody who's this far down the road and, kind of failing a really important antiarrhythmic drug by having secondary side effects from it? Maybe we want to hear from EP and advanced heart failure on this one.
Challenging case, Lisa. Amiodarone is probably our most effective drug for ventricular arrhythmias, but can have pulmonary complications, hepatic, thyroid, ocular, and others. And some patients may need to stop taking it. Generally, other antiarrhythmic drugs have already been tried or used. Switching to them is problematic with the pharmacologic properties of amiodarone. It takes a long time for it to dissipate, for it to leave the patient's body. So starting another drug that also prolongs the QT interval, a potassium channel blocker, is practically difficult. So ablation would probably be strongly thought about in this situation. Ablations are even a little bit harder in general in ventricular arrhythmias than atrial arrhythmias. One of the reasons is thickness of the ventricle compared to the atrium, and we're obviously talking about extra thick ventricles here. So it can be more challenging. Sometimes it can involve ablating on both sides of the septum. Sometimes it can involve infusing alcohol into a vein to create a localized infarct, a little bit similar to alcohol septal ablation for obstruction. But catheter ablation could easily be considered in this situation. It's palliative. It may not cure all of the arrhythmias, but could reduce the chance of ventricular tachycardia and ICD firing. And I'll just mention there are new energy sources being developed. I was on a webinar earlier today about pulse field ablation that may supplement our ability to do ablation in cases like this.
Chuck, I hope that was helpful to you. I don't know if anybody else has any input.
Yeah, Jim, I was just going to add, like, I feel like there are patients that I've seen every couple of years with different ventricular arrhythmia problems, and that technology is moving pretty fast. I mean, you mentioned pulse wave, but there are new catheters, new experience with different approaches. And so I do think that things that may not have been treatable 20 years ago by ablation may be treatable today for sure.
Yeah, that's a good point, Adam.
So, seeing as Adam is making one of the last comments of the night, and we talked very, very briefly about xenotransplant, the idea of building our own hearts in pigs. I love pigs. So our slogan at the HCMA many years ago was "There's no cure for HCM, but someday pigs might fly." And we're heading to a day where not only the pigs are flying, but the pigs may actually have some answers for us. And I spoke to some guys down at AHA who were in the industry of breeding some of those pigs, and they're kind of amazing. And I just want to remind everybody, when you think we've hit like real science fiction and we're doing really amazing things, that there's so much more cool stuff right over the horizon. We're talking about using artificial intelligence for diagnosis. We're talking about xenotransplants. We're talking about gene therapy. And if we had this talk 3 or 4 years ago, Andrew, we wouldn't have come up with half of this stuff in like, oh, we're going to need to create some educational tools around this real soon. But here we are. And we're at a really exciting time for HCM discovery, for partnerships, for advancing the field, and providing better therapies to families with HCM worldwide. So, Andrew, as the current president of the HCM Society, of which I am a board member, can you just give us a little bit of where do you think we're going, and how are we going to get there? No stress or no pressure, but
Yeah.
what's going on? Like, amazing times.
A lot's going on, and it is amazing times. You've been in it longer than I have, but as long as 20 years I've been in it, and I've never seen the pace of advancement and change move as quickly in this field. And it's really very exciting for patients, and it's exciting for us to have more options, as opposed to, look, this is all we have, and choose from these few limited options. I think where we're going now, as we have seen in many other areas of cardiology, is how do we generalize the results from clinical trials to give the option and the best outcome for a much wider group of patients than the select in the clinical trials. We touched on this a little bit earlier, but that's really important. The data in many other heart conditions is, oh yeah, statin therapies reduce the risk of MI and stroke. What % of patients who should be on statins are not on statins, right? It's the simple things. And as we get more of these advancements, how do we apply them to as many patients as possible, to those that don't think that they have another option because of where they're located or their access to care or whatever? How do we broaden it?
I have a lot of big ideas that you and I are going to talk about offline about how we can advance access to patients worldwide. The one thing I didn't get to talk to you all about was my recent trip to Brazil and some opportunities that we as a collective community are going to have to help the people of Brazil get access to care. So there's some amazing things happening, and it's going to take a village to raise this. So I'm really happy that you guys are all in our village with us. because we need a lot of people doing a lot of smart things to help access patients where they are and continue to evolve therapies. So I thank you all for your participation this evening. We have no further questions. To those of us joining on Facebook, thanks. You've been with us through to the end. For those in the webinar, if you missed anything, any contact information, this will be up on YouTube tomorrow, so you can catch it there. Or if you have any questions, you can call the office. If you're interested in a clinical trial and you want more information, you're welcome to call the HCMA office, and we may be able to put you in touch directly with the clinical site coordinator and help you get established with one of the many clinical trials that are ongoing right now. We're going to need all of you to get involved and be part of these clinical trials, because it's the only way we're going to advance the science. So thank you all for joining tonight. And to our friends at Duke, thank you for your partnership over the years. Really happy to see Andrew part of the pediatric team officially now. I've known him since he was in training back at Mayo way back when. So you've got a great peds arm over there, and I'm looking forward to being able to make more use out of that for children in the community. So thank you all. Great session, getting some rah-rahs from your followers. So thank you all and good night.
Thank you.